Namaskar and a very good evening to all of you. We are all here for the 5th webinar of the Society of Fetal Medicine UP chapter. Thanks to Society of Fetal Medicine, Dr. Ashok Khurana sir, Dr. TL Parveen sir, Dr. Krishna Gopal sir for giving this opportunity to us. My gratitude to our patrons and thanks to office bearers of the Society of Fetal Medicine of UP chapter, which makes us work in collaboration to benefit from each other's talent of collective intelligence working towards one goal in unison. So now it's an honor and pleasure for me to invite Dr. Anuradha Khanna ma'am, a very vibrant and dynamic president of the Society of Fetal Medicine UP chapter for the welcome address. Welcome, madam.
Thank you very much, Dr. Ritu Khanna. It's my pleasure to welcome you all as the president of this UP chapter, Fetal Medicine Society, especially to Dr. Ashok Khurana, who is the founder, president of this society, and has been given a lot of enthusiasm and informative knowledge to us. And we are really thankful to you, sir. And we are waiting for Dr. Sharda Jain to join also. And I welcome her. She's a very senior, interactive, very informative, I think gynecologist, so far I know about her, and a very senior member. I welcome Dr. TL Parveen, our president of Society of Fetal Medicine here. And he has got immense knowledge. And he always share it as a speaker or as a moderator. It's a very, very informative to us. Along with him, Dr. Jyoti Bhaskar, Dr. Bimal Sahni is the president-elect, Dr. Krishna Gopal, our own secretary, and Dr. Patke, Shubha Patke, Ankur, and Dr. Tamkeen is with us. She's also very intelligent and interactive person, very vibrant also, and our own Ritu Khanna. She is so active and she has got so many tentacles. I cannot imagine how she works. It's really amazing. And the Vishal, who is in Vishal Mittal, who is making all these arrangements. I welcome you all and all the delegates, audience who are going to listen. And it's a great pleasure, especially the topic today has been chosen for the newer aspect of MTPs. What are the resolution after Foxy movements and seeing the ultrasound, that how it is going to change the scenario. And not only this, that it is being from 20 weeks to 24 weeks, but also beyond it. That is very important because the sonologists, they are informing us this is the problem. But it is the gynecologist obstetrician who has to take care and see for the medical-legal aspect of it. Especially, I have been troubled many times regarding hydrocephalus, which develops late, and also the cardiac complications, spine defect, many things which are developing late. And here I welcome you, Dr. Sharda Jain, and I really like you very much personally and listening you at different forum. Immense knowledge and very, very interactive. So I will not take your time, and Dr. TL Parveen sir is going to also discuss different case scenario most like, and we all will be very much benefited. Thank you very much, each one of you. Thanks a lot.
Thank you so much, ma'am, for such loving and encouraging words. Now, it's an honor and privilege for me to welcome a very inspiring, innovative, a stalwart, an institute in herself, and the most admired and respected for her outstanding contribution in the field of obstetrics and gynecology, and that's Dr. Sharda Jain, ma'am. She has been the faculty for 2 decades at PGI Chandigarh and Lady Harding Medical College, the founder and secretary general of Delhi Gynecologist Forum, the member and expert OBGYN in Ethical Committee of MCI in 2018-20, and again in the National Medical Council from 21 to 23. Decorated by the Lifetime Achievement Award and Living Legend Award, many prestigious bodies, and a passion, teaching, the safety of doctors, creating medico-legal awareness. We do so much of clinical work to our best, but scares of medico-legal always revolves around us. And with such a vast clinical experience, and as a mentor, ma'am, I welcome you to share your experience on the late second and third trimester anomalies and its medico-legal implications. Over to you, Dr. Shadaja ma'am.
Thank you, Dr. Ritu, for a very kind words. At the outset, I must say that I am not an ultrasonologist. I am also not fetal medicine expert. Whatever I know as an optician, and now after working for almost 15, 16 years with Delhi Medical Council, and now with the MCI, National Medical Council now, I'm pained at times that doctors are caught, especially gynecologists and few ultrasonologists are caught for not picking up malformations. Anybody patient who comes to the ultrasound person, he knows that he will do the job 100%. It should be correct diagnosis. Like I find in United Kingdom, they have very clearly outlined these are 11 malformations which can be missed. Even anencephaly can be missed in 2% of patients. Cardiac malformations can be missed in 50% of cases. Renal malformations can be missed in about 70-80% of patients. Now they are very categorical, and that's why you don't find litigations there. But here in our country, the litigations are left and right. And I think the time has come. I am definitely pained that depending upon who is the specialist who takes care of them in the state medical council or in various district forums, that a different kind of decisions are taken for against them. And with the huge compensation, we all know that indemnity insurance companies do not come for help. They do not provide any lawyers. And because they are not ultrasonologists, they don't know much about it. They feel shy about sharing their problems and contacting the senior people for the guidance. What is MCI is looking for, or what is the state medical council are looking forward? They want that there should be guidelines, Indian guidelines. Does the FOXI has a guideline? No. Does the Society of Fetal Medicine has guidelines? No. No categorical guidelines on the similar lines as the UK and other people have got it. I think the time has come. If you really want to save, you find a different kind of decisions are coming. For the similar kind of things, there is a penalty of 10 lakhs of rupees or 20 lakhs of rupees, something like this. And if people like expert like me come, I quote that particular thing. Look, in UK, it is said that you can miss out these kind of things. So I feel it is not logical that this is not a negligence at all. You can find that it's a machine game. The person who's sitting behind it at times can definitely miss it, depending upon the position and things like that. Whether it has been done early, whether it has been done late, kind of a thing. So that something can be missed out. So my request to Madam Ritu, and through you, Dr. Ashok Khurana was sitting here, and Dr. Gopal has been sitting here. For the last 2 years, Dr. Gopal had promised me that they will make something like this, but it has not come. I feel the time has come. If you really want to work for the community, if you really want to safeguard gynecologists, then I think we should have things in place which we advertise. आप खाली उसको बना दो, बनाना एडवर्टाइज करना तो हमारा काम है कि ये आपकी गाइडलाइंस है, ये फॉक्सी ने मिलकर और ये आपने सोसाइटी ऑफ फीटल मेडिसिन ने मिलकर गाइडलाइन बनाई कि ये मैलफॉर्मेशन मिस हो सकती है. And I think, Dr. Khurana is very sincerely watching me, what words I'm speaking about it. I think high time has come that 2021 should not pass. In 2021, we should have that kind of a roadmap available. So with these kind of words, I can say, I'm no ultrasonologist. I'm not a fetal medicine expert. So I'm not here to make any comment, but I definitely get pained about it. If UK and Europe can think about it, why can't we think about it for our people? What's the grand use of having so many meetings when we can't have a guidelines of our own land? First, they look up the guidelines of the FOXI and the national guidelines. If they are not there, they look at the WHO guidelines. If they are not there, they go to American College and the Royal College. So with these words, I sincerely feel that Dr. Ritu will see to it that these guidelines come in place. Thank you very much.
I would like Dr. Krishan Gopal sir to, Dr. Ashok Khurana sir to have a few words.
Sir, please. Ma'am, we have our guidelines. That is the guidelines for the scan actually. But the kind of guidelines you are discussing, that the particular defects should be mentioned, that we will walk upon very soon. Thank you, ma'am. Thank you so much.
Ashok Khurana sir.
I think, Krishna, you're right, and we have to pay attention to this. Dr. Shadajan has very clearly pointed out that we need a position statement, a single half-page saying that an ultrasound scan does not guarantee the absence of anomalies, and that the following anomalies are known to be missed. And it is just a question of putting a list together, a nice simple list, and then it will be, legal work as far as anybody else is concerned. And we put it on our website, we put it in our journal, and it becomes quotable. So I think we just go ahead with this post haste, quick speed, and make that list.
I think with today's webinar, I think we can have some sort of a guidelines formed, because we now know, because we are going to thoroughly discuss about the various late anomalies, why they are missed and all. So with this background, I think it becomes very easy for us to put forward a statement.
Absolutely. Yes.
Yeah.
So, madam, I think it will be.
Sir, I just also want one thing. Once the guidelines are made, they must go to National Medical Council. They must go to various state council. And I think, your body should combine with the FOXI, and that then makes a joint guideline. That will be much better.
Yeah.
Yes, we'll work either with FOXI or with the ICOG, one of the two, whichever one can work with us faster.
Yes.
So, thank you, madam, and you've put us rolling. And so we would work on it, and we back to you also with so much of assurance from our whole SFM team. Thank you so much, ma'am, for enlightening us on the unrevealed conundrums of genetics. Your experiences are always learning lessons for us, and we always appreciate your amazing vision. Thank you so much for giving us your precious time, ma'am. Thank you so much, madam. So with this, we move on to our scientific session, and I invite our chairpersons for the session, Dr. Anuradha Khanna, madam, very, very meticulous and exuberant personality, professor and ex-head of Department of Obstetrics and Gynecology, Institute of Medical Sciences, BHU, has immense teaching experience, and we love always to listen to her. She has also been the past president of Varanasi Obstetric Gynec Society and is the president of Indian Menopause Society, Varanasi chapter. Countless publications and lots of awards to her credit. Welcome to you, madam.
I think everyone knows that. You proceed, yeah.
I also welcome Dr. Tamkeen Khan, very outstanding and brilliant, professor and head of Department of Obstetrics Gynec, JNMU, Aligarh University, and past secretary, Aligarh Obstetric Gynec Society, with interest into fetal medicine and high risk. Welcome to you, Dr. Tamkeen, and over to the chairpersons for the session.
I request Dr. Tamkeen to introduce Dr. Ashok Khurana, sir.
Pleasure, Dr. Anuradha. Professor Ashok Khurana, MBBS, MD, from All India Institute of Medical Sciences, New Delhi, and MD Radio Diagnosis, also from the prestigious institute, trained at Herlev Hospital in Denmark in ultrasound, chairman and consultant in reproductive ultrasound at the Ultrasound Lab, New Delhi, practicing ultrasound in New Delhi since 1980. We have been hearing about him, right since our postgraduate days. Professor, School of Health Sciences, Dubrovnik International University, Croatia, Professor, Indian Medical Association, 2017-2020, past president of the Society of Fetal Medicine, former ICOG in International Society of Ultrasound in Obs and Gynae, ambassador in India, editor-in-chief, Journal of Fetal Medicine. And I think what he has done for fetal medicine and fetal ultrasound in India is simply amazing. So, and this all academic activities that he's been continuously doing, the amount of energy and personal details, that he looks into each and every aspect of the academic sessions. So it's such a privilege for me, and I'm really honored to be introducing.
Thank you very much, Dr. Tamkeen. And it's always a pleasure to listen Dr. Ashok Khurana, and that too today is the most vibrant topic, that is rules and regulations, what modification has come that will help in the management of our abnormalities and how to manage, how to proceed. Thank you very much.
Thank you. Thank you very much. And a big hello to everyone. It's a pleasure to be back to academics after that a big hiatus. I'm just checking to see whether you're able to see my presentation or not. Is anyone able to see my presentation? I'm getting a peculiar message here.
Yes, we can see your presentation.
It is visible.
So it is on, yes?
Yeah.
Yeah, wonderful. So like I said, it's a pleasure to be back after the festival season, and we've chosen a very appropriate topic, and I congratulate the UP chaplain, Dr. Ritu Khanna, for choosing this, delayed second and third trimester anomalies, a relook in the context of the MTP Act 2021. And we know that we've been struggling with this at Foxy as well as the Society of Fetal Medicine for over 11 years. This act was formulated in 2010. We introduced it to the parties in power at that time, and we thought we'd be through in a few months. We were number 612 in Parliament in the Lok Sabha in October 2010, and we went slipped, and the bill never got passed. It was up to the presidents of Foxy, Dr. Pai, and then Dr. Jaideep Malhotra, who pushed it. The original person who really put this act together was Dr. Nozer Shariar. And thanks to his efforts, we actually sat and formulated this paragraph by paragraph. We had to fight the NGOs because they were coming up with miscellaneous considerations that I and a lot of others from felt that were not woman friendly, and we thought that was not correct, and that a safe termination under the original MTP Act was also a part of the fundamental right of every woman in our part of the world. And so we pushed and we pushed. The act finally came through in the Rajya Sabha after being passed in the Lok Sabha in March this year. It was again almost getting postponed, but thank God it happened. And more importantly, we now have the rules. Whenever an act is passed in this country, there are rules that we have to go by, and those then get formulated at Nirman Bhavan, at the Ministry of Health and Family Welfare, by an expert group. And on October 12, these were released in the Gazette of India. So everything that I'm saying today is now part of the law. And we will take you through things like this, which is microcephaly, achondroplasia, bowel atresia, etc., which almost always are discovered late in pregnancy. If you look at this classical chart from Dario Palladini's textbook from many, many years ago, and this is from his second edition, you will realize that there are, of course, some which are diagnosed only after birth. In a significant number of cases, there are many of these cranial abnormalities, as well as the bowel and kidney abnormalities that are diagnosed only after birth. And there are some which will, and there are some out of these which will always be diagnosed only in the third trimester, such as achondroplasia, for instance, venous aneurysms, all the congenital tumors, bowel atresias, and kidney disease. And therefore, interest has been rising. The interest started about 20 years ago, and this is a series of the papers that led to this new interest. And finally, we realized that last year in the White Journal, Ultrasound and Obstetrics and Gynecology 2020, we got a paper from Kypros Nikolaidis and his group, which talked about the value of routine ultrasound examination at 35 to 37 weeks of gestation, where the incidence of abnormality was pretty high, 2%. And more importantly, 7.4% were detected for the first time postnatally, but 24% of the 995 were detected for the first time at the 36-week scan. So that really is the importance, and the panel discussion following this will take this forward. The important of this thing for this is that it forms a very important part of selecting the time and place for delivery and making sure that intensive care and surgical care are available, postnatal investigations are available, and this improves postnatal outcomes. So there is no doubt now that we do need that scan apart from assessing for growth restriction, etc., also for this. Now, why do we see abnormalities late? And I'll give this background before we go down to the legal aspect. One, of course, there are anomalies which are identified in the first or second trimester, such as this omphalocele, investigated, non-genetic basis, patient is counseled and decides to carry on. And therefore, we will see it again when she comes for a 36-week scan. There are some that have been missed because they were too small, or we know that we don't pick up all abnormalities, and you then end up picking them later, such as this tiny lumbosacral meningomyelocele with a tethered cord. And this was obviously one of the missed ones. And then this has its own aspects of counseling. And these are the ones that are now playing a large role in what is governed by the new MTP Act. What do we do about these anomalies? How do we explain the prognosis? Who decides what is to be done? And where does the permission for MTP come from? Exactly the same thing happens. Applications of this new law for those that are never picked up in the second trimester, in the early part of the second trimester, which means never in the anomaly scan, such as polycystic kidney disease. And you see here large kidneys, but they're never really seen before 22 to 24 weeks, usually at about 26 weeks. And therefore we will spot them only in later scans. Then of course, there are those that evolve during pregnancy. And then what do we do about these? Can we terminate these if they have a horrible prognosis? Well, some of them we can and some of them we cannot. And therefore we then have this. For instance, here we have this very echogenic ventricle in the heart. And we know that this is critical aortic stenosis. It's something that starts in pregnancy, but starts early in pregnancy, but is manifest only later. And therefore we need to think about it much later. And then, of course, there are some that will develop because of an infection or a vascular incident, which is much later in pregnancy. And so by definition, again, this would be categorized into a late second and third trimester anomaly. So this is the panoramic view. And now the law helps us to handle these differently. We've been handling them all along. And we do understand that illegal terminations have been taking place with impunity all over the country because of the empathy and sympathy one feels for these patients. But we did realize that we were stepping on very, very difficult ground and illegal ground too. And therefore we needed this support. And thank God we have that support now. And we will discuss that in the next few minutes. We also understand that, as we just discussed prior to my talk, that in the best of centers all over the world, a lot of the anomalies are missed at the time of the anomaly scan. And therefore, all of these here, the ones in green, are the ones that are truly picked up at greater than 23 weeks. And this is from the EuroCat data, which is a European registry. And so it's not that we are anywhere far behind. This happens all over the world. And I think it's a very good idea, as Dr. Shada Jain has suggested, that we put together something like this for ourselves as well. And so I will take you through some of these things. And this will also be covered in the panel discussion. And a very simple example is the fact that, look, every structure does exist very early in pregnancy, but we don't see it as a structure except much later. And everything evolves in pregnancy. So we have an L-shaped ventricular system of the brain at 7 weeks, a C-shaped at 8 weeks, smaller ventricles by about 9 weeks, and an almost 12-week kind of pattern by about 10 weeks. The brain continues to develop throughout pregnancies, as it does in the first 2 years of life and beyond. And therefore, the sulcine gyration would appear much later. Obviously, then, if there was going to be a disturbance, you and me will have to face this disturbance much later in pregnancy, because that, after all, is evolution. That, after all, is physiology. And like we discussed, some of this is etiology. So vascular things will be like this. The other thing about physiology is, for instance, if the fetus is not urinating enough, as it does not in the first and the early second trimester, you will not pick up obstructive urinary disease. And because the fetus is not swallowing enough in the first and early second trimester, we don't pick up obstructive bowel disease. And so The bowel dysplasias and the urological conditions and the restrictive cardiac conditions are all things that we see much later. And I've already mentioned some others, but remember that microcephaly falls into this category. Agenesis of the corpus callosum often falls into this category, and some of the posterior fossa anomalies also fall into this category. We also have a fair degree of the cardiac lesions that need to be looked at, and we will discuss this briefly. And importantly, skeletal dysplasia is the most common. Achondroplasia is almost never picked up before 24 weeks, and usually between 26 and 32 weeks when it manifests as polyamnios or during a growth scan. So what do we do with these? Today we handle them differently because there is now a change in the legal limit of termination of pregnancies in our country. By the powers invested in it, the Ministry of Health and Family Welfare notification came out, like I said, on the 12th of October 2021, and has been notified by which a pregnancy with an anomalous fetus that has a questionable quality of life or a severely impaired possibility of quality of life can be terminated at any time during the pregnancy. The earlier rule was the 20-week deadline. That no longer applies, and let us study what are the clauses that govern this. Implication number one is that the routine mid-trimester anomaly scan, which we very wholeheartedly still call the level 2 scan, it's not the level 2 anymore, we've gone way beyond level 2, can now be shifted to a 20 to 22 week window, which has a higher detection rate. This is a graph I have been showing you for the last 20 years, maybe more, and it clearly shows that at 18 weeks of pregnancy, I would pick up between 50 and 60% of the anomalies that exist. And at 20 or 22 weeks, I would pick up about 70 to 80%, and the graph keeps rising as pregnancy progresses. So obviously, I have this window that I can now use. If I do an anomaly scan at 20 or 22 weeks, it still gives me a large enough window for second opinions, for counseling, for multi-specialty consultations, further evaluation with genetics, MRI, and other lab tests as necessary. And even if genetic evaluation moves into a second or a third tier of testing, that means, okay, my karyotype came normal, now I need a microarray, my microarray came normal, I need an exome sequence, or I need a Sanger sequencing, what do I do? There is no proverbial sword now hanging over the neck of the patient or the obstetrician, and we have an answer for these in the new MTP Act. So the first thing is a shift to the 20 to 22 weeks window for our mid-trimester anomaly scan rather than the old 18 weeks window. What about implication number 2? Implication number 2 is in clause 3B of the new rules, where you find that women eligible for termination of pregnancy up to 24 weeks includes category F, which means that fetal malformation that has substantial risk of being incompatible with life, or if the child is born, it may suffer from such physical or mental abnormalities to be seriously handicapped, then that patient is entitled to a termination of pregnancy up to 24 weeks of gestation. And it's not that this was a random figure. The figure remains that the quality of resuscitation is such in most parts of the world that we really don't have intact survival before 24 weeks. So it would therefore qualify as a miscarriage or a termination of pregnancy. The important part of implication 2, which I just read out to you, is also there in these rules, which clearly says that we can go beyond 20 weeks till 24 weeks, and we have to fill up Form E, and we require the opinion of 2 registered medical practitioners. So up to 20 weeks is the same old rule, 1 registered medical practitioner. 20 to 24 weeks, we can have the opinion, we can have the signature on Form E, which 2 medical practitioners have to sign. 2 questions come up immediately. Where do I get a copy of Form E? And where do I get a list of the permitted fetal malformations? Immediate answers before everybody starts choking my chat box. Google, you will find this list over there. You can also go to the Ministry of Health and Family Welfare, Government of India website. And of course, By tomorrow, it will be on the SFM website as well. And we wanted this discussion to be held before we go ahead to see what format would be best for putting this up. And so this would be where you get the Form E, and you will get the list of the permitted fetal malformations. We prepared this list in 2010. And in 2010, it was a lesser long list. Now it is a longer list because we've understood a lot of conditions better. And therefore, I will not go through the list in this webinar, but certainly in the future. We then have implication number 3, which is really the most far-reaching implication as far as the Indian woman is concerned. And that is that the Act empowers the state to appoint a medical board which will allow or deny termination of pregnancy beyond 24 weeks of gestation period. This board is constituted, and the rules are given there, with a gynecologist, a pediatrician, a radiologist, and anybody else that the board asks for. And they can also ask for additional investigations. But there are two very, very significant, important caveats here that help the woman. And that is that the opinion of this medical board is to be provided within 3 days of receiving the request for medical termination. Beyond 24 weeks, a woman petitions the board, and within 3 days, she will get clearance from the board, and the state is obliged to her to terminate that pregnancy within 5 days of the receipt of the request. Very, very far-reaching, like I said, and very, very important to empower the women of India. The important thing is that this is something that is now clear, and therefore we now have clear differences between the old Act and the new Act. We're waiting for one clarification, and that is which legal forum. Does the woman who is beyond 24 weeks and has an anomaly of this type petition the court? That means a writ petition, which is by definition the High Court, or can this be done in the district court? The rules that we put forth before this act was passed clearly indicated that it was still the High Court. The new rules have not left this very, very clear. And so we have put in a request that we would like to know whether this can be done at the district court level, because that is what was originally requested by us at Foxy and at the Society of Fetal Medicine. And both me and Dr. Jaideep Malhotra, who was the president Foxy then, had said that it has to be at the level of the local court. So wherever you have a district court, and that's never far from a village today, we still have the right to carry out this kind of a situation. The things, therefore, that we will take you through this evening are background information, which will be more in the panel discussion as well as hardcore counseling. And I will go through some of the things we've already touched upon. And the reason why we take you through this is to remind you that we need to assess prognostic factors. We need to have a knowledge of legal considerations and patient options. We need to know how to prognosticate pregnancies, and we need to know how termination of pregnancy is not necessarily the most sensible outcome in a lot of these. There is a tendency in the Indian population to want a perfect baby, and they don't want to get hassled, and they will never accept the fact that a termination of pregnancy might result in an abnormal scarring of the uterus, the Asherman, so to say, and that they may never conceive again. Therefore, it's very important to realize that we have to put everything rightly into perspective, and we cannot trivialize this law by using it for minor abnormalities. So primary prevention, of course, how do we prevent getting into all this? Well, we can stop obstetric and ultrasound practice, which is not the answer, of course not. What we do need to know is, of course, that we ensure that as many patients as possible are offered anomaly scans, that the limitation must be documented in the report, that the patient must be counseled before, during, and after the scan, and that patient-specific limitations must be documented in the report, and that would be primary prevention of trouble arising from this. So the backbone of this whole story is counseling, counseling, and counseling. And of course, do remember at the same time that you and me must keep our indemnity insurances high and up to date, the maximum possible. Moving into the second part is the protocols. Dr. Krishna Gopal referred to these. These protocols, which are from the Society of Fetal Medicine, were first published in 2014, clearly indicate that during the anomaly scan, we do not detect all anomalies, and therefore this does not guarantee the absence of an abnormality. But as we've discussed a few minutes ago, we will make it more specific and make it into a list and put it out as a position statement of the Journal of the Society of Fetal Medicine, and possibly take on the support of either FOGSI or the Indian College of Obstetrics and Gynecology. Let's do a few examples. The sacral meningomyelocele, for instance, and here we know that there was this tiny lesion that got missed. And what we learned, that there's a level of the lesion, a tethering of the cord, there are associated abnormalities, some supratentorial signs like ventriculomegaly, and there might be an underlying cause such as a folate abnormality. There's a huge list that we go through, but the important thing is the next step, that after associated abnormalities, a review of the family history and a history of teratogen intake, genetic consultation, discussion of the quality of life issues, an MRI, and a multi-specialty consultation, a rehab consultation, a on-site consultation with a whole board of these specialists, or a virtual one, which now has become easier. We have to then move on to giving not just delivery at a tertiary center in this 29-weeker, but the option of a late termination. So this is how our entire counseling is going to change as a consequence of this act. So knowing that there are severe limitations in the outcome of this pregnancy because of the fact that the seal is so low, because of the fact that there is ventriculomegaly already, then there are quality of life issues. And therefore the patient has a right to decide whether she wants to carry on with this or not. And this is not something unique to India. Patients in many countries, including Germany, have the right to decide even at 37 or 38 weeks of pregnancy, and then with a lethal injection of potassium chloride into the fetal heart, the fetus is then ended so that it can be delivered as a fetal which has had a demise and not as a living fetus. So it's not that it's something new. The concept is not new, just that it is for us something that is new. Another one that we often encounter, corpus callosum, we get beautiful reports and images from ultrasound. We know that we have measurements to support us. We know we do vaginal scans and add on color and 3D wherever necessary. The point is that we then go through the genetics of this whole situation. We get an idea of what's going on, and we add on MRI, which then gives us excellent ideas. Again, once we have a full prognosis, we say, yes, in the next pregnancy, we look for it in the first trimester. What about this pregnancy? Does this lady actually have to carry on if we were to discover an agenesis at 32 weeks? Not anymore. If she decides that she's not happy with the fact that there's a 90% bad outcome and that we don't know which fetus will have that bad outcome, she now has the option of late termination, again, after a full workup with genetics, MRI, and a multi-specialty consultation. So now, even if my exome takes long or my gene panel takes long, it doesn't matter. I have an answer for this lady, and I do exactly the same exercise for a dural atresia, for instance. So with my dural atresia, if I were to discover it like I usually do at 31 weeks or 29 weeks because of polyamnios, I will again look for associated abnormalities. And if I find a trisomy 21, I know I am again stuck with an abnormality of a type where the quality of life is compromised. What do? I offer late termination to her as one of the possibilities. And if she wishes to carry on, of course, she may carry on. So everywhere now, we now have this possibility that would be very, very simple for us to follow. Of course, we have to make sure that our ultrasound basis is absolutely correct, that the ultrasound has been done well, and perhaps take a second opinion before we start the ball rolling to find out more. I'll summarize with a few more interesting areas where we need to do this. Achondroplasia, for instance. And here we start wondering, because although we have a physical abnormality and they do have lumbar canal stenosis and they do have a cultural isolation, and we do think of them as circus dwarfs because our thinking is so cheap and low, we do start wondering whether we should offer them a late termination or not. The fact remains that the family can now sit down together, think of this by themselves, and weigh in their own mind what they're going to do in the next pregnancy. Obviously, although most of these are de novo, we would repeat that in the next pregnancy at 12 weeks. But importantly, realize that here there would be quality of life issues for the child, there would be cultural issues for the child, there would be the mother's fundamental right to termination, and we have to take all of these into consideration during our counseling. But that option of late termination definitely exists. So although we now have a NIPT for free fetal DNA at 12 weeks, and that's only for the next pregnancy, it's not going to help me with this pregnancy. Here, I will consider each one of these and as many counseling sessions as she wants, because we've already been doing terminations as late as 32, 34, and 36 weeks in several states in the country over the past 2 years since the interim rules had been put in. A similar decision on urinary dilatation, we follow the same thing that we follow always. However, if we find that as a consequence of all of this, we do have a risk stratification where we are on the more serious side, where the renal pelvis is more than 10 millimeters, and there are abnormalities such as a bladder outflow obstruction, and we find that our first trimester clues that we then go back to look for were not so nice, such as an umbilical cord cyst, and there was a thick nuchal translucency, but the karyotype was okay. What do we do then? We start thinking of the possibility of telling the patient that, look, this has a poor prognosis, and it doesn't help too much at this stage to do with psychocentesis. The window for that is 16 to 20 weeks, and we couldn't see this at that time because the PUV wasn't really there. We now give them the option of late termination. The same thing occurs for cardiac abnormalities, and a lot of these actually evolve, such as the hypoplastic left heart, the coarctations, and so on, and the effects are not seen until later in pregnancy. We differentiate between the ductus dependent and the non-ductus dependent. We then say, no, this is not for termination. Give this child an option and see whether you'd like to be delivered in a tertiary care center. For many of them, there are treatments available, and we should not restrict ourselves by saying that, look, it doesn't happen in India. Give them the option that if you go to that part of the world, you can have some of these which are already in clinical care, some of these which are salvage types, some of these which are still research protocols, but do give them an option. And after our full workup, then we say, okay, this is what you can do. And then they can decide for themselves whether they want a late termination or they're quite happy with what's going on. So my take-home message is we now have a great new law, but before we start pushing that as our main advantage to terminate all pregnancies with an abnormality, do understand that we need a complete workup so that we get to know the prognosis. We must include good imaging, good genetics, and exclude associated abnormalities. We should not limit the use of technology. We then need to know the natural history and outcomes, have a working knowledge of the surveillance of these when the patient carries on and the treatment options all over the world, facilitate multi-specialty consultations, and that is what the Society of Fetal Medicine is all about, and then go on with counseling, and the option of late termination. And thank you so much for your attention.
Thank you very much, Dr. Shokurana. It is very, very informative for all the obstetrician and the sonologist, and also to the pediatrician. And not only pediatric medicine, it is mainly pediatric surgeon, because whenever the anomaly is there, we have to discuss with all this multidisciplinary team so that we can decide and take whether it is treatment is possible or not. If possible, what will be the way? And we have to see the affordability of the patient. I try to refer many cases from Varanasi to SGPGI Lucknow, to AIMS at Dr. Aparna Sharma, and also Deepika Deka is there nowadays. But you see, they refuse, and they go back to the doctor who has referred to me, and they say, "इतना तामझाम नहीं कर सकते मैडम, इसको हटा ही दीजिए, अगले में देखेंगे, पता कर लीजिए कि अगला ठीक ठाक होगा कि नहीं, ये पता कर दीजिए." This is their layman language, and we have to respect it, because our 90% population, they do go like this. Only 10% they are having affordability, or they are living in a high-tech centers. So we have to see accordingly. And regarding the allegations, the 90% they don't go for medical legal allegations because they accept it. It happens. मेरे घर में पुराने भी ऐसा हो चुका. But those 10% who are with high tech and they want perfection in all the field, actually they go for allegation from the very beginning. Once the conception has occurred, that if we are going for ultrasound, even TIFA, as you said, 18 weeks only, 60% is diagnosed. At 23 weeks, it is the 70% only diagnosed. So that means we have to tell that though we are going to get it done, but still it's not 100%. You will have the problem. And what I do in my practice, I ask them to write it on my prescription. They write it on my prescription that though TIFA is normal, yet in 30%, 40% cases, still I can have anomaly later on, or which may not be visible. This is very, very important because then they cannot say anything. You will develop the guideline, very good. That is awesome. But since we are not having guidelines, we can counsel like that in our practice so that allegations will not be there. Let guidelines come. But now the Dr. Jaideep Malhotra and you, and along with you, Dr. Jaideep Tank, he was also there as a general secretary when these guidelines, new MTP Act has come, and they help us a lot. And really, it was a very, very informative talk of you. And Dr. Thielen Praveen is going to be more discussion with the cases. That will be awesome. Thank you, all of you very much. Thank you, Dr. Khurana.
Thank you.
Just add something if you people allow
Sure,
me, and we are not. Yeah, I think he's given us very, important intricacies and nuances and implications of the act. And also, the way he categorized the anomalies. And one very important message that Dr. Khurana gave us was that now we can delay that's level 2 scan so that we improve the pickup rate of the anomalies. And he's also made a very important, a very responsible statement at the end and given us so much food for thought when he said that do not trivialize the landmark changes in the MTP Act for minor anomalies. Everybody wants designer babies, perfect babies. But as responsible doctors, we have to think about that, the counseling that we do. Also, we have to look into it that people do not start, circumventing the PCP&DT Act, use it for circumventing the PCP&DT Act. And also, as a pre-humanist, I would just like to add, we keep on talking about the woman's right on her body, but we forget that the fetus also is a person who has some rights. So on the one hand, we have a baby in UK who has cystic fibrosis, who's suing his own parents that why did you not terminate me? And there is another, baby of Focomelia who's giving TED Talks, and they're down babies who are participating in Paralympics. So we need to think about that. So we can only detect morphological anomalies. We can just think about the functional impairments that those anomalies can have, but we cannot diagnose a Hitler in utero. So how much damage to human race or his right to live should be justified, we have no idea about that. So we have to have a balance between all these philosophical questions. Thank you very much. Thank you so much, Dr. Ashok.
I agree with you, Dr. Tamkin. I totally agree with you. But since we have got a newer living, at least TIFA should be done at around 18 to 20 weeks, which will have many things be done. And we have got enough 4 weeks time so that any major thing is there. So everyone wants to have a almost 90% normal baby, and 10% can, as you said, may have. But if you ask me, not only this, if one baby is abnormal, the family suffers so much that the family is not able to produce a second one. And then they come at the age of 37, 38 years or 40 years to me and to you. Then what to do? Another problem. So it's very important to go for TIFA and have the thing done. And if required, NIPT or non-invasive, or if required, invasive. That is very nice. And I will like to go for it. Thank you very much.
So I think it was a wonderful session with an excellent and a very informative deliberation, Dr. Ashok Khurana sir. And thank you, Anuradha Khanna madam and Dr. Tamkeen, making it so interactive. So thank you so much. And before moving on to the next session, Mr. Vishal, we can have the video. So we move on to the next, just a minute, I'll just stop share and put the slide, other slide share. So moving on to the other next awaited session, and that's the panel discussion. And I would like to introduce our moderator for the same. Dr. TLN Parveen sir, a luminary, a very passionate teacher, and has a fabulous art of encouragement. He's the president, Society of Fetal Medicine. He received numerous honors and awards and has got countless publications to his credits. And to introduce with the panelists, we have Dr. Jyoti Bhaskar, a very courteous and enthusiastic personality. She is a clinical director, obstetrician gynecologist, Apollo Cradle Hospital, Indrapuram, Delhi NCR, president of Delhi Gynec Forum East 21-23, and also has received the Teacher of Teachers Award from DGF 2017. Welcome, Dr. Jyoti. Dr. Bimal Sani sir, a proficient and humble personality with remarkable radiological skills, as the president-elect, Society of Fetal Medicine, Director Sonoscan Center, Aurangabad, and numerous publications to his credit. Welcome to you, sir. Dr. Krishna Gopal sir, very talented, I must say, and ambitious personality. He is the National Secretary, Society of Fetal Medicine, a part of the Working Committee of Society of Fetal Medicine for Fetal Echocardiography, and also the Training and Teaching Faculty for Delhi Gynec Forum, editor for Fetal Medicine Journal of Springers International. Welcome to you, sir. Dr. Shubha Fatke ma'am, an energetic and a very cool personality. She's the professor and head of Department of Medical Genetics, SGPGI, Lucknow, and with interest in pre- and postnatal dysmorphology, genetic diagnostics, psychosocial issues in genetic counseling. Teacher for DM also for the past 25 years, 294 publications, and founding president of Society of Indian Academy of Medical Genetics. Welcome to you, madam. And also we have Dr. Ankur Mandela, a very humble and loving with a meritorious career. He is an additional professor, Department of Pediatric Surgery, SGPGI Lucknow, and interest into minimal invasive pediatric surgery, fetal diagnosis and therapy for lesions, surgical lesions, neonatal surgery, pediatric GI and hepatobiliary surgery. More than 40 publications and 6 chapters in the books. So we have a good learned panelist, and over to you, Dr. TLN Parveen, sir.
Thank you very much, Ritu Khanna. Now I will share my screen. Okay. Good evening, everybody. And before I start, I would really like to congratulate Dr. Ashok for really putting forward such an wonderful talk, particularly based on evolving abnormalities, the way we are going to go about approaching them, diagnosing them, and the present MTP Act, which is going to be extremely useful. And I think he has enumerated in such a way that we now very clearly understand what exactly the implications of this particular act and what are the things that we need to go about and what are the things we are going to make use of in counseling our patients. So with this, I think let me take you through a session which we are going to face in our day-to-day practice. So these are the patients who are going to come to us. And when we start evaluating them, the problems which we are going to face, and we need to understand why third trimester scan. That is an extremely important thing that we need to put forward, and the message which I want to put forward as far as this particular webinar is concerned. Now, a brief account, as we all know, the major congenital abnormalities occur in about 3 to 4% and minor anomalies in about 7 to 10% of the population. Whenever there is an anomaly, it increases the risk of aneuploidy, syndromes, as well as poor perinatal outcome. And congenital anomalies account to almost about 22% of infant death. And fetal malformations, they increase the morbidity and mortality in the neonatal and postnatal periods. And as we all know, ultrasound is the primary imaging modality. Of course, complementary, we have the MRI imaging in evaluating congenital abnormalities and obstetric problems. And it is performed by real-time, high-resolution images. And we have additional tools with us in order to make out these abnormalities, such as the Doppler, transvaginal ultrasound, 3D, 4D ultrasound, as well as in order to evaluate the fetal anatomy as well as the physiology. Now, we have a specific timeline. See, we all know that we have been pushing hard to diagnose congenital abnormalities or structural abnormalities as early as 12 to 13 weeks of gestation. And not only that, we try to evaluate them in the second trimester, particularly. Till now, we have been limiting ourselves to less than 20 weeks, and that is the mark that we were always worried about. But now with this MTP Act, we are a little more cautious, and at the same time, we have much more leverage and try to make use of this particular act in better evaluation or better assessment of these antenatal patients. And then the second trimester scan, where we always call them as an anomaly scan, and the third trimester, which was conventionally known as the growth scan. And now the anomaly detection, whichever has been done in the first and second trimester, are also found in the third trimester. But only thing is, they may remain static, or they may progress, or they may regress. So that is the reason why we need to do a third trimester scan. So we can call this third trimester scan as a relook or a review scan. So with this brief introduction, there was a wonderful paper which has been published in UOG, that is the White Journal 2020, which is called as the value of routine ultrasound examination at 35 to 37 weeks gestation, which is by the Nicolaides group. And in this, they have mentioned various aspects of evaluating or routinely examining 35 to 37 weeks, and what are the limitations as well as the advantages that we are going to get. Now, with this background, I have a wonderful panelist. And the panelists, thank you, Ritu, for introducing the panel. And we have Jyoti Bhaskar, who is an obstetrician, and Bimal Sahani, my close friend, who is a radiologist, and Krishna Gopal, our secretary of fetal medicine. And then Shubha Phadke madam, who is the geneticist from SGPGI, and Ankur Mandelia, who is also a pediatric surgeon, also from SGPGI. Now, with this elite panelist, I would like to take you through various aspects which can make us proper utilization of 35 to 37 week scan in evaluating our patients. Now, first thing is, let me ask Dr. Jyoti Bhaskar. Ma'am, quite often in your practice, I'm sure you would be asking for a third trimester, ordering for a third trimester scan. And what do you expect by ordering this particular scan in the third trimester?
So thank you very much, Dr. Khurana and Dr. Ritu, for having me. You know, having a look at the panelists, it looks to be really a multidisciplinary discussion that we're going to be having today. So coming to the question, Dr. Praveen, when I do order a third trimester scan, there are for two reasons. One is planned as a part of my protocol, and the other, it can be for emergency conditions when the patient does come to me. So when I'm ordering for a planned protocol based for my own self, then the main purpose, first of all, is of course the growth. The reason that I want to know is that, is there any FGR that is setting in? Is the baby going to be in overweight? What is that like? So it gives me a good idea about the growth that is progressing. So I do not miss out an FGR and land up with an IUD later on in that. The second purpose that, of course, we have been discussing today is to detect the anomalies. It's not just about detection. It's about a review to see whether these anomalies which were missed out previously, can we detect them? Which were there previously, are they progressing or evolving, or are there any other new anomalies which are coming on to this? So when it is this, the other group is also the high-risk pregnancies. So these high-risk pregnancies, I'm anyway getting the third trimester scan done from 28 weeks onwards, which is done every 4 weeks, which is for the growth, taking a right time for decision for delivery. The third aspect is the emergency ones. This can be done if a patient comes to me with bleeding, if she comes to me with leaking, or if she comes to me with decreased fetal movements. That's the time I want to know what exactly is the position of the baby. Is the placenta low-lying? Is there any accidental hemorrhage that is present? What is the LICA? So, or is the, if you're doing a fetal movement is coming reduced, then of course I need to know everything about the baby, the Dopplers and everything. So this is the predominant reasons that we do get a third trimester scan.
Thank you, Dr. Jyoti Bhaskar. It was wonderful that you have put in three important aspects why you ask or what you expect from the third trimester scan. Now, with this, I would like to ask Dr. Krishna Gopal, as a radiologist and as a fetal medicine specialist, what is the checklist you follow whenever you come across a third trimester scan which has been ordered by your clinical colleague?
Thanks for making part of this wonderful meeting. We all in the practice develop a certain checklist over the years. So what the checklist I follow in my practice is I just do in two parts. First is the maternal survey and the second is the fetal survey. So in the maternal survey, I go for the length of the cervix, internal os, lower segment in case of previous cesarean section for the cesarean section scar, as well as a myometrium to look for the fibroids or any ovarian cyst. That is the maternal part. Then in the fetal part, we look for whether it is a singleton or a multiple. What is the lie? What is the presentation? Then the placental morphology and its distance from the internal os, the inferior end, then the amniotic fluid volume, just not with the index, amniotic fluid index, rather subjectively as well. Then we go for the heart rate, rhythm, whether it is regular or not, and then the biometry itself. How is the weight? How is the AC? Whether the other biometrical parameters are falling within the range or not. Then we should carefully look for the fetal anatomy for any defect that has been developed since the last scan. So that is why that is how we can cover whole of the checklist. We can also add nuchal cord also if it is there, whether there is a single loop or the multiple loops.
Thank you, Krishna Gopal. So now we are very clear about why a third trimester scan is being asked by the clinician. And as a radiologist or an imaging specialist, what are the checklists that we have to follow in evaluating these particular scans? With this background, let us ask my friend Vimal Sahani, why are these anomalies detected in the late second and third trimester scans?
At the onset, thank you, UP chapter, for having me here. And as regards this question, why do anomalies, why are they detected in the second or third trimester? See, we can put them into four segments. One is, there are certain anomalies which are progressive and progressive and evolving, because they have a natural history. It's not, they may be present in the second trimester. You may just find very, very subtle findings which are just borderline, and you may not, you may ignore them. But as the pregnancy progresses, then they become, they progress into full-fledged anomalies. The most commonest of them are the urinary tract dilatation. You may just have very, very subtle pelviactasis, but later on they get into a full-blown hydronephrosis there. A second segment is where you have anomalies which become apparent only in the second or third trimester. And here the causes, you have certain things like, because some structures have an embryological timetable, sir, where you have a corpus callosum which is going to fully form at one particular stage. The sulcations and gyrations would become evident only at a particular embryological timetable. So now that is the reason, we find certain anomalies which we are able to pick up only in the late second or the third trimester, because as long as you have pointed out, before also, and everybody keeps talking about it, that we cannot hasten embryology. So we have to understand that. Then we have a third segment where these are true late onset. Now, these true late onset anomalies, these could be tumors, which we know generally occur later in pregnancy, or then due to some maternal events like infection or vascular insult. Of course, these can occur anytime, but then they usually occur in the late second or third trimester, and that is, so all these anomalies you're going to pick up later. And then, as Khurana sir has pointed out, and you pointed out, then we have the achondroplasias and all. So, and then there is a fourth segment, which you can put them into two categories. One is that, they've been missed, maybe because of a very poor sonographic penetration at the time of the mid-trimester scan and the small size of the fetus, or they have genuinely been missed because a proper protocol has not been followed. So that is one segment, which actually, honestly, is a missed anomaly. But if you take your mid-trimester scan as a routine scan, you're bound to miss certain things in that also.
Thank you, Bimal. It was wonderful and nice that you have put it into category wise. One you said as the progressing abnormalities. Two is an evolving abnormality, which is a late onset abnormality. Third as infections and insults. And the fourth one being possibility of a missed abnormality. And we use this late second and third trimester scan as a second opportunity to evaluate these abnormalities. Thank you. Now, Krishna Gopal, what are the factors which are responsible for this late detection of abnormalities? Are there any factors which are responsible for this sort of a late detection?
Sir, there are many factors, but I will just repeat the golden words again, that you cannot hasten embryology. Embryology has a certain velocity, and you cannot make it quicker in some way or the other. Plus pregnancy is an ongoing event. It is a dynamic event. So many of the events are going on, and you have to see that event at that particular of the time only. You cannot see it earlier. Plus there are certain limitation, because when it is of a smaller size, like if there is a tiny sacromeningocele, myelomeningocele that is not seen by the naked eye in the earlier phase, that can grow to a certain size in the late second trimester or the third trimester, and we can see it well. And plus there are also some technical factors, like in a very obese patient, you see many of the things later on, like if the baby grows, it might go in the upper part, where there is a less amount of the fat, and the things are better visualized. Like VSD, they are so tiny earlier, but they can be seen later on. In fact, in cases of aortic stenosis, if you see, the heart is normal size earlier, but all those changes you see in the late phases.
Right. Thank you. So our panelists have put forward wonderfully why these anomalies are missed, or why these anomalies are detected late. And not only that, they have also enlightened us regarding the factors which are responsible, because these are practical problems which we are going to face in our day-to-day practice while we are evaluating these patients. So these are the two most important factors that we have to keep in mind while we are evaluating a third trimester scan. Now, they made it very clear that the most important thing is that you cannot hasten embryology. That is one. And it is time to face and introspect the risks, benefits, ethical, social, and legal issues arising from anomalies detected late in pregnancies. Not only that, the tendency is that the patients as well as the treating physicians want conclusive answers, whether the normalcy of the fetus or not, which becomes very, very difficult, as we all know that pregnancy is a dynamic event. So these are the things that we have to keep in mind while evaluating a third trimester abnormality. Now, what are the, Krishna Gopal, I would like to know, what is the incidence and fetal abnormalities first seen at 35 to 37 weeks of gestation?
Sir, in in these week in the later part of the pregnancy, it is approximately 2%. In the paper you have referred, that is a very good paper published in the White Journal by the
Nicholas. Yeah.
and the group. So it is 1.9% approx. There are most common abnormality. Those are first seen in 35 to 36.6 weeks are hydronephrosis. You might see a very, very mild pelvic characteristic in the early phase that can grow to a gross hydronephrosis later on. VSD that might be tiny, that has been developed later on. Ventriculomegaly that can evolve later on, duplex kidney that might not be seen earlier, ovarian cyst and arachnoid cyst that might be either too tiny or they can grow. In our practice, many times we see that we can diagnose even mesenteric cyst earlier, and that can either grow or they can resolve also later on. So as we have discussed in the discussed, pregnancy is a dynamic event. So many things keeps on changing later on.
Right. Thank you, Krishna Gopal. So he has given us an insight into what are the common abnormalities that are detected. And another important question I would like to ask Krishna Gopal is, what are the anomalies exclusively diagnosed in 35 to 37 weeks? And what are the anomalies which are first detected in the postnatal period?
Sir, those are the ovarian cyst, microcephaly, achondroplasia, dacrocystocele, and hematocolpus. Those are first seen only in the latter part of the pregnancies only, and incidence of abnormality first seen post-natally is 0.1% approximately. Anomalies first detected postnatally are the isolated cleft palate, polydactyly, syndactyly, ambiguous genitalia, like so on.
Yeah. So these are the things that we need to keep in mind while we are evaluating late second and third trimester scans, so that we know that these are the things that we might not have detected. See, the same patient might have come to us for the second trimester scan or an anomaly scan. And in the third trimester scan, when you do a scan and you find this sort of an anomaly, you need not be disturbed, because these are the ones which are exclusively diagnosed in the 35 to 37 weeks of gestation. Now, keeping this in mind, why do we have to diagnose an anomaly at 35 to 37 weeks? Jyoti Bhaskar, in what way does it affect your management?
If you're getting an anomaly scan at 35 to 37 weeks and a patient comes to me with a written anomaly on it, it helps me in making several important decisions. First of all, it helps me to find out when I need to deliver this patient. Second thing, where I need to deliver the patient. And the third thing is how I need to deliver this patient. So first, as far as we are talking is when, so that would depend upon the seriousness of the anomaly, whether I need to deliver at 35 weeks or I can take the patient at 38 weeks. So that would actually depend upon the survival of the baby once the baby is out. So that is something that we will have after a discussion with the pediatrician to exactly know when can I deliver this baby to get a good outcome. The second thing is the place I need to deliver. Again, that is after a discussion with the pediatrician, pediatric surgeon, or a cardiologist, depending upon the anomaly it is. It will require a tertiary care. Would it require a surgeon to operate on the baby? Would the baby require a cardiological care? So these will help me to decide exactly the place that I need to deliver this. The third factor that is very important is the mode of delivery. Can I allow this patient a vaginal delivery, or would the outcome be better if I take the patient for a cesarean section? And more importantly, it gives me time to be able to discuss with the relatives, with the parents, and give them time to prepare themselves and even prepare myself. And later on also discuss so that we get a better outcome for the baby. So if I know this, I'm well prepared, the parents are well prepared, the pediatrician is well prepared, so that ultimately we all as a team work to get the best perinatal outcome.
Yeah. Thank you very much. So that is the advantage of having this second look or a review scan at 35 to 37, not only for the growth, but also to pick up certain anomalies which are very exclusive for this particular period of gestation. And these are the advantages that has been enumerated by Dr. Jyoti Bhaskar. Now, Bimal, what are the main indications for a 35 to 37 weeks? And when a patient is sent to you at 35 to 37 weeks, quite often, what are the indications that you find in the requisition that has been sent to you?
Yes, most of the time, the indications of, the primary indication, as Dr. Jyoti Bhaskar pointed out right in the beginning, is that, this scan primarily is a growth scan. And you're asking for evaluation of growth and fetal well-being. And in that, the Doppler becomes a part of it, looking at the Leica. And so that is primarily the indication why we get this 35 to 37 weeks scan. So normally you're not going to end up as an indication that, yes, nobody is going to ask you to look out for anomalies at 35 to 37 weeks. So they are primarily coming for a 35 to 37 week scan to rule out growth, to rule out growth disorders. I would like to pick up, the SGAs, and then whether it's just an SGA or a fetal growth restriction, and then whether it's an early onset or a late onset. So all these factors would come in there. The second important point is, of course, at times all these things would become a part. The fetal environment becomes a part that we look for the Leica, we look for placenta, and all those things has been enumerated by Krishna Gopal. But then at times the indication could be that, yes, clinically they're feeling that there is polyhydramnios, or on clinical examination, they find that the size of the uterus appears high. And that is one moment. It's not just looking at the quantum of Leica which is present. Of course, clinically also they know it is polyhydramnios. That is the time when, because we know a lot of these evolving anomalies or the third trimester anomalies would actually, polyhydramnios is an important criteria for those things. So, and that actually makes us look for it. And so I personally feel that unless you really think over that, yes, as a part of, whatever is the indication that patient has come to you, looking, as you nicely put it, it is a relook scan. So we need to take this opportunity and have our own protocol for the third trimester also. Yes, it may not be as exhaustive as we have for the second trimester, but we can have a protocol for our own. Okay, this is at least, these are the certain things that I'm going to look for, because the pickup rate in third trimester, you're talking about 35 to 37 weeks. Practically, I would say that the pickup rate for anomalies would be better at around 32 to 34 weeks, the earlier part of the growth scan. 35 to 37 weeks, it becomes still more difficult. You may not be able to take a look at the complete fetus. But we just, it's if the patient is high risk, yes, we are really looking at. Low risk, we end up missing certain things. The quality of machine will also come into picture. And it is just the attitude. I would say it is just that, yes, you have to, there's nothing called a routine scan. There's nothing called a routine scan. So it's not just about looking at the heart activity, just because we need to do one scan at 35, 37 weeks and end it over. I think everyone has to take a look at the anatomy also.
Thank you, Bimal. You have conveyed a very, very important message that it has to be taken with seriousness. That is, it's not just the growth. Yes, definitely at 35 or 32 to 34 or 35 to 37 weeks, we are interested in evaluating eclampsia. We are also interested in evaluating small for gestational age fetuses, as well as a macrosomia or a large for gestational age fetuses. At the same time, we have to give equal importance in evaluating for abnormalities, particularly when there is a clinical suspicion such as poly or an oligo, where we need to explain the cause for poly or an oligo. Not only that, we need to understand that there are certain phenotypic expressions of these abnormalities which become apparent only after 20 weeks of gestation. So that is the reason why we need to focus. We cannot, as you correctly said, we cannot label any scan as a routine scan. There is nothing like a routine scan. Every scan who comes for your evaluation should become a part and parcel of your regular protocol, which you are going to follow, whichever the period of gestation they come to you for evaluation. Thank you. Next, Krishna Gopal, what is the approach that you are going to take in evaluating the third? Now, Vimala said that there is nothing like a routine scan, and he said that it's a relook scan. So what are the things that you are going to look for at the third trimester?
Sir, basically the cases we have been sent for the growth scan. So the primary aim is to see the fetal growth, amniotic fluid volume, and do the multivessel Doppler. But my message to the audience is that always look the patient, look the fetus clinically. Like if you are seeing that patient is developing gestational diabetes, you have to look for all those anomalies. Those are associated with diabetes that you can see in the late second or third trimester. Similarly, if you are seeing one sign like the polyhydramnios, so it is always open that you should look for the causes of the polyhydramnios. Plus, even if the patient doesn't have any history, doesn't have any sign, make it a protocol to examine the baby thoroughly, systematically, with all these limitations. We know that there are limitations, but still make it a protocol to re-examine the baby from tip to toe, and the same manner in which you have examined it in the second trimester anomaly scan, as far as possible. With all those technical limitations, there might be reduced amniotic fluid volume, there might be obesity, many of the things. But when you make your own protocol, then most likely you are not going to miss anything.
Thank you very much. That's a very important message that Krishna Gopal has conveyed to all of us, that we need to meticulously evaluate the third trimester fetus. Now, Bimal, what is the followed approach of anomaly detection at 35 to 37 weeks? Well, how do you follow them, and what is your approach?
Okay, sir. See, my approach once we see this, of course, see, as you pointed out that on the screen, on the slide, that we need to know, okay, which is the major organ which is affected that is there, and then whether it is simple or complex. Now, in a particular system like in the heart, if you find only one particular thing, then it could be a simple anomaly. If you're finding more than one, then it could be a complex system. Third thing is, for me, it is also important that everyone should know that all these cutoffs that we talk about, because you put in about the hydronephrosis here. See, the cutoffs in the second trimester and the cutoffs in the third trimester are different, sir. Because you would probably label a 5 millimeter, 6 millimeter APD in the second trimester as mild, but in the third trimester, then it's between 7 to 10, which is mild. So these are things also one should be aware of. But for me, I would like to classify them. Once I have seen this, I would like to classify them into whether it's lethal or non-lethal, whether the morbidity is high or the morbidity is low. These are two very important things. And third is whether it is isolated or are multiple abnormalities present. And then if I move to the cardiac thing, if I see a cardiac anomaly at this stage, at 35 to 37 weeks, of course, along with the lethality and all those things, what is most important for me is this particular anomaly a ductal dependent or not a ductal dependent lesion? So similarly, in every system, you need to have some things, because it's not just about making a diagnosis and putting across. We need to we need to help our obstetrician, because we are also going to counsel the patient. So unless we don't provide all this information, it is difficult for them also to plan this thing. And based on that, a specialty opinion can be taken prenatally, and that would all be based upon whether we are able to say that yes, because there are a lot of, as you pointed out, there are so many non-specific things like left subclave in LSVC or in ARSA. They're not going to make too much of a difference. But coarctation of aorta, aortic arch hypoplasia, definitely. If I'm finding critical aortic stenosis, definitely. So these are the ones which are not lethal, but they are the ones which require immediate attention. So we would put them into that kind of a category. And so I think it is important that we explain everything. And once you see one finding, I know it is very difficult in the third trimester to spend, to look at the complete anatomy. But then if you find one problem, you give it all the time that is possible. and because that actually impacts the postnatal outcome.
Yeah. Thank you. Thank you, Vimal. It was wonderful. And you have really concised the things which are going to help us in our day-to-day practice, because this is the approach which we have to follow in evaluating these patients, counseling them, and helping your clinical colleague in coming to a decision as far as the time, place, and mode of deliveries are concerned, and taking the clinic, the other other specialities to into consideration in order to counsel these patients. Now, in a third trimester scan, actually, after 2 normal scans, we can categorize them as development-dependent abnormalities or cause-related abnormalities such as infections, vascular insults, hemorrhages. Anomalies become evident due to pressure gradients like congenital diaphragmatic hernias or a ventricular septal defect. Anomalies related to sequelae like clubfoot renal abnormalities. Progressing anomalies like GI abnormalities, skeletal microcephaly. Delayed occurrence like tumors, renal, wherever the tumor it could be, and then the anomalies due to fetal movement restriction like skeletal abnormalities. And another important point Dr. Bimal has conveyed is that it is essential to categorize them, whether it is isolated or in association with other abnormalities, whether they are lethal or non-lethal. So this is a very, very important practical approach that we have to follow in evaluating these fetuses in the third trimester. Now, with that, I'll just take you through some of the abnormalities. I'm not going to go in detail. These are one of those commonest things which we try to evaluate, and quite often they are evolving abnormalities like the cortical defects, and then the cardiac abnormalities, as well as the ventricular septal defects, and then we have the other things like the cause-related abnormalities like infections, vascular insults, and hemorrhages, and then we have the intraventricular or periventricular hemorrhages, which can be late onset, late second trimester or third trimester. Quite often it is the third trimester diagnosis. And then the cause-related like chorencephaly and schizencephaly abnormalities. And these are all the various abnormalities which we will come across, like anomalies becoming evident due to pressure gradients like the diaphragmatic hernia, as well as the ventricular septal defect, and renal abnormalities, which may be initially thought as about 17 weeks, 20 weeks, and 35 weeks, what we have a progression of the calyceal dilatation, which is going to have an impact on the perinatal outcome. So keeping these in mind, we need to evaluate all these abnormalities. I'm just taking through various abnormalities which we can come across in third trimester. Duodenal atresia, as Dr. Ashok has shown us in his talk, and then the small bowel obstructions, as well as microcephaly, one of the most problematic situations that we come across in the third trimester, and achondroplasias. These are the things that we need to keep in mind, and the tumors, as well as the neck and face masses can also be there, ovarian cysts, and then the rhabdomyomas or the right ventricle. These are the tumors that can come across, and the renal vein thrombosis. So now, Dr. Ankur Mandelia, we have shown you that these are all the various abnormalities that can be picked up in the third trimester. And what are the abnormalities that are first seen postnatally? As a pediatric surgeon, I'm sure you will be coming across these abnormalities in your day-to-day practice. Can you please enumerate us the abnormalities that you come across in your practice?
Yes, sir. So good evening to all. I thank the society for having me on this panel. And thank you for the question, sir. So as previously mentioned, the abnormalities which we first see postnatally, which are not seen even on the third trimester scan, is I think around 0.1%. And some of these will be like an isolated cleft palate or a poly or syndactyly, something like an hypospadias or an ambiguous genitalia, which is very difficult to detect antenatally, or say an anorectal malformation, because the baby is not supposed to pass meconium in utero. So these anomalies, unless it's a very, very focused ultrasound and even an MRI, these usually will be detected postnatally for the first time. And very rarely, very, very rarely, we will see them antenatally. So these are some of them which we will see postnatally.
Okay, thank you. So we're keeping that in mind. Bimal, can you tell us the clinical implication by detecting these anomalies at 35 to 37 weeks of gestation?
Sir, again, the clinical implications, you can put them into the category. First of all, yes, you are finally prenatally diagnosing it. That's a very important thing. Whatever said and done, something coming as a surprise postnatally, maybe even at 36, 37 weeks, but prenatally you have done that. That is an important implication there. The second important implication is whether, we need to do any genetic testing if required. Of course, 35 to 37 weeks, this would not go about, but maybe if it is a little earlier, say somewhere around 30, 31 weeks, that option is still there, that because we can consult a genetist on that. And because if, like Dr. Khurana pointed out, that yes, the law now says that it can be terminated at any time with the permission of the medical board. But then the medical board would want if you want to send this patient to a medical board, there has to be a complete workup which has to be done. Exactly. Then termination of pregnancy, and as that is what comes into it. Now it can still be legal. You don't need to go to a quack and go and get it done. You move around, but for all that, no medical board is just going to take up one ultrasound report and say, okay, yes. So a complete workup would be required there. Then the very important thing that takes place here is it gives us an opportunity to involve a pediatric specialist prenatally, sir. So if you have made a diagnosis at maybe 35 weeks, 37 weeks, or maybe even 39 weeks, but before this thing, you involve a pediatric specialist in the sense whatever we are dealing with. If it's a cardiac problem, we have a pediatric cardiologist, and we involve them prenatally. The patient gets ample time to be prepared for what needs to be done immediately after that. Then, as Dr. Bhaskar pointed out, the place of delivery. I'm not getting into the time of delivery or the mode of delivery, because as a radiologist, that becomes the domain of an obstetrician. But then they're also going to take a decision based on what all we put together at the 35 to 37 weeks. But the place of delivery becomes very important. So even at 39 weeks, 4 days also, if I have picked up and if I say that, yes, this is a ductal dependent lesion, then I know this delivery has to be in a center where there are facilities for a pediatric cardiologist, of a facility where prostaglandin can be given after birth. Even at late trimester, if I say, yes, there is a very strong possibility of an esophageal atresia here, that one diagnosis can save the life. We have a pediatric surgeon sitting here, something which a baby, if he knows beforehand that, yes, this baby has a very, very strong suspicion of an esophageal atresia, before the baby aspirates, things would, and the outcome drastically changes where, the baby is born unaware and then the baby aspirates, and the surgical outcomes would also differ. And last and the most important clinical the implication is counseling, sir. And okay, that I think we take it as a separate this thing, but yes, counseling is the most important thing, which actually for me becomes the, if I talk about late onset anomalies, I feel that part becomes a very, very important part, more than just picking up that particular thing.
Thank you, Vimal. Thank you very much. Now let's go to the counseling part. As Vimal said, that is the most important thing when you detect a third trimester anomaly. And how do you counsel these patients? I want Dr. Jyoti Bhaskar to react. And how is she going to counsel this patient who comes back with a report saying that there is a third trimester anomaly that has been detected after two normal scans, two normal previous scans? Jyoti Bhaskar.
Dr. Praveen, it's a nightmare. It's going to be really difficult to do it, and to do it alone. So at such a particular situation, first thing I'm going to ring up my radiologist or the ultrasonologist who has done it, talk to him personally and find out what exactly is the problem. Thereafter, I sit down with the patients and I tell them, first of all, we have to be ethically and legally correct when we are counseling this patient. Not a single word is going to be said where it tends to say that it was not picked up previously, they're
Exactly.
adequate, they're not going to be good. So that lies upon our substitution because the patient depends and is first connected to me. So for me, it is very important that I'm not going to speak any such word which labels any fault with anyone. But I'm going to tell them that these particular anomalies are the ones, as we've been talking, they tend to evolve or they may have just appeared for the first time, and that this is the right time to pick them up. These particular words have to be used more with these particular patients. Then, depending upon the type of anomaly, I'm going to ensure that we do have a meeting with the pediatrician or the pediatric surgeon or the cardiologist, and combined together, we then counsel the patient about the prognosis. So I'm not going to take the responsibility alone, even though the patient, I'm the primary consultant, but I'm going to involve the whole team so that we can give them a wholesome answer and even the process that's going to happen and what the outcome is going to be.
Thank you. Thank you, Jyoti Bhaskar. It was wonderful. There are two most important points that she put forward. One is that she would not utter a word which is going to affect the other specialist. That is one. Two, she is going to counsel the patient based on the help from other, that is the teamwork, like taking the pediatric cardiologist or a pediatric nephrologist or pediatric urologist. So this is an extremely important aspect that we need to understand regarding the patient's side. Now, Krishna Gopal, what are you going to do? You have scanned her previously, or someone else has scanned the patient previously, and she comes for a third trimester scan to you, and suddenly you detect an abnormality. What is your reaction, and how do you counsel these patients?
If the patient say that it is a nightmare, so we have our double nightmare. We have to counsel not only patient, we have to counsel our referring doctor as well. So first you do the scan, you sit with the patient, you counsel them in detail. Many times you take the computer links also, you give them an idea of the published papers as well. What I have learned from my experience, that three things I always do. First is I write my counseling in my report. That is a small para, the fetal medicine counseling. Whatever I say them in black and white, I write it there first. Second, I call the referring doctor. Third, I always put a team together as told by Dr. Jyoti, that if I diagnose a cardiac defect, then I always write down that a prognostication by the pediatric cardiologist. So I always try to arrange a meeting with the pediatric surgeon or the pediatric cardiologist as well. I rank them personally. I discuss the case with them, and I arrange a meeting. So what you need to do, you need to take the patient in confidence. You make them aware also that these are the defects that cannot be seen at this particular point. You have to make them aware that pregnancy is an ongoing event, evolving thing. Then put all the team together. Never tell a single nasty word about your colleague, whosoever have done the scan, and then always counsel the patient and tell them truth. If possible, print out the literature, give them to read and assess by themselves.
Thank you, Krishna Gopal. That was wonderful. Bimal, I think you are very vocal about counseling. So let us hear from you. How do you counsel these patients who had a previous scan, either done by you or by someone else? And what do you think about this positive counseling?
Sir, I won't get too much into the scientific part, which both Krishna Gopal and Dr. Jyoti Bhaskar have already spoken about. But one thing, what I agree with Krishna Gopal, it is a double nightmare. Because breaking the news of an anomaly picked up at the second trimester is far easier than breaking it when an anomaly is picked up in the third trimester. Because till the time the patient comes for a TIFA scan, these days they're all aware that yes, malformation, because we use terminologies like malformation scan, anomaly scan. So, they're stressed. They
Right.
know that there is a possibility that something maybe, they'll keep asking you, is everything normal? Are there any anomalies? But by the time they come to you for a third trimester scan, all those things have gone out of their mind. They've already had their baby shower and everyone has been informed. So the situation is very different for them at that moment. So they are coming to you more for a reassurance that the growth is fine and the liquor is okay and the baby is moving well, which they also say that. So this is the time, I think, first and foremost, once you see an anomaly while you are scanning, never ever ask a question to the parents that, did you get any scan done before? I will never ask that. I may take their file, go check later on, in my cabin whether there were. But if the moment you ask them this question that, okay, didn't you get a scan done in the 5th month? Then once you break the news, the whole story goes on that, yes, it should have been picked up at that time. So, and as I always say that at times they could probably say that, yes, sir, you have only done the previous scan. So you could be on the receiving end at times like this. Second thing, this counseling should be, you have to give time to the patient. You need to spend some time with them.
Yes.
It shouldn't be a standing saying that, no, there is a problem in this and all. Okay, this is your report. Go and show it to your obstetrician and this thing. No, that is the time you really, make them sit outside, call them in your cabin, very nicely tell them that, okay, in this, first start with the positive things. The growth is normal, the liquor is okay, but then we are finding a problem in the fetal heart or this thing. So you just go about very, very slowly in the most compassionate way possible. And at the same time, because if you know that, yes, this is treatable or this thing, at the same time, you keep telling them that, yeah. And because I maybe in another 3-4 months, I will come up with this talk of mine, which I've been requesting Khurana sir to give me an opportunity to speak on, is how to douse the fire. Because see, all these things that we have been talking about, that these are evolved, patient has nothing to do with that. So the only question they will ask, they will not ask about the prognosis first. The only first question they ask is, why was it not picked up earlier? So the whole story, so you have to douse the fire. Whoever has done it, whether you've done it or anyone of your colleague has done the scan, because now we all know that, yes, these are the things which can evolve and will be. Like one example I'll give you, sir, a few months back, I had a patient at 35, 36 weeks, come for a growth scan. I found that there was a unilateral microphthalmia. Now, how do I put this across to them? So I sat with their file. In front of them, I was seeing their 20-week scan and everything. And then I told them, see, this left orbit, which was growing fine till about 20 weeks. After that, probably it has stopped growing. So I am telling them what it is, but at the same time, I'm not making it too harsh that this was not picked up earlier and all. So I think that is an important message that, yes, we have to see to it that we are not speaking. And Dr. Jyoti Bhaskar said that she will call the radiologist. I think that should not happen, because I am the one who's primarily picking up. I will call my obstetrician and inform them that, yes, this scan which we have done today, this is showing this and this. Because the most important part is that everyone should speak the same language. The problem about the patients getting upset is when all the radiologist speaks a different language, the obstetrician speaks a different language, the pediatric surgeon speaks a different language. So the best part is communication. This is a team counseling. So yes, we are not going to sit together and do it. The best part is, use your phone, call up all the people concerned who are going to get involved eventually, tell them about the problem. At times, it is very difficult to write down so much about certain things, but while you're explaining to the pediatrics, because the pediatric surgeon may have a few extra questions, or a pediatric cardiologist may say, okay, this is there, but what is the size of the pulmonary artery? So I can relook and help them out.
Yeah, thank you. So it's very nice that Bimal has put it in a very, very clear way, that your counseling should be proactive, compassionate, and positive. So these are the three attributes that an imagiologist should have in counseling these patients, because they're stressed. I mean, once you say that there is something abnormal, whether it is in the second trimester or in the third trimester, they are definitely stressed, more so in the third trimester, because they, as it is said, that they are expecting everything to be normal, and the only thing they are concerned is the baby's weight. Quite often you ask, what is the weight of the baby? So they come with that mindset, and suddenly you disclose that there is something. So when you want to put it across, you need to be very, very compassionate as well as positive in your counseling. Thank you very much, Jyoti Bhaskar, Krishna Gopal, as well as Bimal, for putting across a most important aspect of this third trimester anomaly detection. Now, coming to Ankur Mandelia, can you please enumerate the postnatally correctable anomalies detected? Okay, we have diagnosed an anomaly. We have counseled the patient, and the obstetrician has also seen, and then we refer it to you. And what are all the various abnormalities that can be corrected? Dr. Ankur.
Yeah. So, sir, most of the anomalies of gastrointestinal system or urological or thoracic anomalies are now correctable. I'll not comment on cardiac or skeletal anomalies, as I'm not an expert on cardiac or skeletal anomalies. But we can just divide these anomalies into those which require urgent or immediate surgery in the neonatal period in the first 30 days of life. And we can see anomalies which do not require surgery immediately, but might require surgery in later infancy or childhood. So, anomalies requiring immediate surgery among the gastrointestinal system will be all the atresias, starting from esophageal to intestinal, which require surgery in the first 48 to 72 hours of life. Complicated meconium cyst or a cloacal anomaly with hydrometrocolpus. We get babies who are born with a huge hydrometrocolpus. They have huge abdominal distension. So they definitely need either an interventional drainage or a surgical drainage. Among the urological anomalies, posterior urethral valve is one which we definitely look for in a male baby who antenatally had a bilateral hydrouretronephrosis with a thick-walled bladder, oligohydramnios, sometimes even a keyhole sign. So there definitely, if we have seen it antenatally, we ask them to get delivered in a tertiary care center, and we see them immediately, and we start the treatment. So posterior urethral valve is something which definitely needs correction, and it's correctable. But the correctable thing is also like, to what extent can we correct it? Like, as you know, like PUV or meningomyelocele, we can correct it. We can correct the anatomical problem, but many a times the physiological problem stays, like a thick-walled bladder resulting in wall bladder syndrome, or a meningomyelocele resulting in neurological deficits, which cannot be corrected even after repair. So correctable is a relative term, I'll say. And among the thoracic anomalies, often we see congenital diaphragmatic hernias, which are correctable. But again, I will say some of these babies really don't make it to the operating room. Like diaphragmatic hernias, which are antenatally diagnosed, inherently have a bad prognosis. So some of them after birth are really very sick. Even at SGPGI, we are not able to take some of them to the OR, and they sometimes succumb even within the first 24 to 48 hours, even with the best of NICU care. And again, you can tell the parents it's correctable, but whether you will be able to correct every diaphragmatic hernia, it's really a question which needs to be seen. Other anomalies like CPAM or sequestration, bronchogenesis. So the surgery actually depends on the level of respiratory distress the baby has. Sometimes even a large CPAM, the child may be totally asymptomatic and have normal saturations on room air. And sometimes even a small bronchogenic cyst compressing on the carina can have severe distress after birth, and we need to go in immediately and do a lobectomy or a cyst excision. So they can go either ways. So we counsel, if they are seen antenatally, as we just discussed in detail about counseling. Whenever we are called in at SGPGI, we try to do a combined counseling with the fetal medicine person, the neonatology expert, and we sit down and we tell them all these things, that the child may require some surgery immediately, may not require surgery immediately, and we will do the best what is required for the baby. Neurological anomalies, neural tube defects, again, we will like to operate them early as the infection rate is less. Severe ventriculomegaly might require a shunt or a drainage early. So these are some of the anomalies which require surgery immediately. If we go to some of the anomalies which do not require surgery immediately but might require surgery later, something like duplication cyst of the intestine or a choledochal cyst, which are not symptomatic at birth but are likely to become symptomatic in the first 3 to 6 months and usually require surgery in infancy. PUJ obstruction with a normal opposite kidney does not require immediate surgery. Reflux, vesicouretic reflux, duple anomalies, ovarian cysts, these can be followed and treated as per the symptoms and as per the progression of the disease. I talked already about hydrocephalus and lung anomalies. Some of the tumors which we see antenatally, tumors are rarely diagnosed, but something like a sacrococcygeal teratoma or an adrenal lesion. So a large tumor will obviously require surgery early, but say something like a neuroblastoma, an antenatally diagnosed neuroblastoma has a good prognosis. So you can follow these, and sometimes they don't require surgery. A neuroblastoma detected antenatally may completely disappear by 6 months of age. They don't require anything. So you just have to do a repeat scans and do your markers and everything and follow them very closely. Cardiac anomalies, as you know, some of them require surgery immediately, something like a TGV or a TAPVC, which are duct dependent, as we saw earlier in Sir's talk, and they require a cardiac evaluation. And many of these anomalies coexist. The cardiac anomalies are very common in something like an esophageal atresia or an anorectal malformation or a neural tube defect. So some of the cardiac anomalies take precedence over our repair if it is really duct dependent and they are very severe. And orthopedic anomalies usually are can be repaired later, like a polydactyly or a talipes. So it's a long list. Sorry for the long answer, but yeah.
Thank you that you have given us a wonderful insight into what are the various correctable abnormalities. How are you going to approach? Now, another question to you: how do you want the fetus to be delivered and the neonate to be taken care of as a pediatric surgeon? What do you expect from the obstetrician or the NICU?
Yeah, so a very important question, sir, and it's I think the management starts right from the counseling and from the diagnosis and the counseling, and as we discussed earlier, the entire team has to be there. The radiologist, the obstetrician, neonatologist, the pediatric surgeon, the entire team has to counsel them either through telemedicine or in a physically, if possible, in your institute. And usually after detecting a second or third trimester anomaly, so what we say is again we go to the time and place of delivery. So the list I mentioned, so all the anomalies which require an immediate or urgent surgery in the first 30 days of life, they definitely should be delivered in a tertiary care institute where good NICU facilities are there, good facilities for pediatric surgery and pediatric anesthesia are available, good facilities for radiology, especially say neonatal CT or MRI can be done. Then you need facilities for postnatal care, NICU, and so all these we definitely tell them to get delivered, to get registered in our antenatal clinic, and they get date. Sometimes they are even admitted a few days before the planned date of delivery so that the whole team is ready and a bed is reserved for the baby in the NICU, especially in a setting like SGPGI where the beds are very limited. You cannot come in with a baby with a severe anomaly and expect to get a bed every time. So all these planning has to go in deciding the time and place of delivery. The timing of delivery is controversial in some diagnosis, like say severe hydronephrosis or a PUV, where earlier it was thought that you can deliver early to save the kidney, but now many studies have shown that you should deliver nearer to term for lung maturity, and doesn't make much of a difference for the renal outcomes as such. So most of the anomalies should be delivered near term, and it doesn't make much of a difference for renal outcomes and things like that. But the mode of delivery and the time of delivery is best left to the obstetrician team. Anomalies like unilateral hydronephrosis or lung anomalies which do not which might not require an immediate surgery, we usually tell them to, if logistically not possible to get delivered at a tertiary care center, say a unilateral hydronephrosis with an opposite normal kidney, we tell them to get delivered at a good hospital near their place. And we ask them to follow up with us with at least one postnatal scan at 2 to 4 weeks of age. And then we do our own investigations in our institute, and we make the diagnosis and do a postnatal counseling and follow them up after that. So I think this covers most of the aspects of postnatal.
Thank you very
care.
much. So this is about how do you want the fetus to be delivered and the neonate to be taken care in the pediatrics? That is as far as the neonatal care, you have already mentioned everything about this. Thank you very much for your inputs as far as a pediatric surgeon is concerned, so that we are aware of how to prepare the patients, how to counsel the patient regarding the postnatal care, and so that the importance of a pediatric surgeon involved in the team is made very clear. Now,
thank you, sir.
Madam, nothing is complete without genetic evaluation, whether it is in the second trimester or third trimester. An anomaly detected definitely needs a genetic testing. What is your call on, Professor Sudha Patke, Madam?
Thank you very much for this opportunity to participate in the interesting discussion. Though this question has come at the last, but the first thing, as soon as some anomalies detected, whether it's in the first half of the pregnancy gestation or after 20 weeks, the two most important things are necessary. First is, what are the associated malformations or anomalies which can be seen by ultrasonography, and second is there some genetic disorder which can be diagnosed by prenatal sampling and genetic investigations like chromosomal analysis and test for monogenic disorders. So this is very essential, because if there are associated malformations suggesting some syndrome, or if there are any genetic abnormalities suggesting some genetic syndrome, the outcome totally differs, and hence then the possibility of surgery or what interventions will be the outcome will not depend only on that, because if there is duodenal atresia, then we tell the family that 30% of the fetuses of prenatally detected duodenal atresia have trisomy 21. So duodenal atresia is easily treatable, and that should be treated after birth. However, the child will have some developmental disability of variable severity, which cannot be cured by surgery or by surgery of duodenal atresia or any other mode of management. Hence, investigations to find out genetic etiology are very, very important. I would like to group these disorders into three types of groups. First is those with lethal abnormalities like anencephaly, or maybe severe ventriculomegaly, holoprosencephaly, and where probably lethal skeletal dysplasias, where the genetic investigations are necessary, but not for prognostication, but only for counseling regarding risk of recurrence during next pregnancy. So these investigations can be done prenatally or on postnatal sample like cord blood or piece of umbilical cord for DNA testing and so on. Of course, I usually prefer that when the patient has come to us, then collecting amniotic fluid sample is very useful, in the sense it has advantage that you can keep on growing fibroblasts in the amniotic fluid, and that can be a continued source of DNA later on. Because if you collect fetal blood and somebody sends only 0.5 milliliter of ETA blood, then if that gets over, then further investigations may not be possible. The second group of malformations, what I would say that duodenal atresia or something like that, which need immediate surgery, diaphragmatic hernia, esophageal atresia, but some of them will have chromosomal abnormalities, and we cannot for the family to go ahead with a costly surgery or to go ahead to some other center may depend if there is the fetus has chromosomal abnormality or not. So for this early, whatever may be the gestation, even 28 weeks, 30 weeks, 32 weeks, one would prefer to do testing, as for many of the genetic testings, the reports are available within say 4 to 7 days or at the most 10 days. And hence these investigations become very important for these group of disorders where immediate surgery is needed and it's a surgically treatable condition. Same with cardiac anomalies also, because cardiac anomalies, the surgery facilities may not be available at even many big cities for neonatal surgeries. And hence, if the family decides that if the child does not, and chromosomal abnormalities are very common, 40% in prenatally detected fetal cardiac anomalies, then if there is chromosomal abnormality, then they may not really plan to go to some other big city, Delhi or somewhere. But if it is not there, then they can go for surgical treatment there. The third group of disorders, as Dr. Ankur said, that something like unilateral hydronephrosis or something, unilateral multicystic kidney, where the child may need surgery later on, even if many of the pulmonary cysts like CCAM, which are small and are not really going to cause respiratory distress immediately after birth. There, the investigations, one can say that probably that will depend on the gestation age. So somebody who has come as 30 weeks, I would say that doing investigations now is not really going to make much difference. I would prefer to get the baby delivered at a good center, evaluate for associated malformations, and then go ahead with chromosomal microarray or whatever test. Because if you see the baby after birth and identify some more anomalies or some dysmorphic features which are not prenatally detectable, then the interpretation of the test results is better if the phenotype results are better. So these are the three type of disorders. The
Thank you,
fourth
ma'am. So you have
just a second, I want to talk about aplasia of corpus callosum, because that has been highlighted and everybody knows that many times it is detected lastly. So there, the outcome with isolated aplasia of corpus callosum is very good with normal development in 80 to 90% of cases. And here also the investigations for chromosomal microarray or monogenic disorders are very important. However, doing immediately, prenatally or after birth may not make much difference, because if the outcome is likely to be high possibility of good outcome, and probably even late detection, even the law allows termination. I think one would really wonder whether if the outcome is so good, whether the termination is justified or not. And that I want to again highlight that even if the law has allowed us, given us option that late terminations are possible, we have to know that still it is ethically would be very, very debatable in many situations, and we should not consider prenatal diagnosis as the first stage to termination of pregnancy. Yeah. We should always, all doctors, and because patients don't know what achondroplasia is. So unless all fetal medicine specialists or counselors, they know that achondroplasia, Down syndrome children can lead and are leading very good, excellent lives. As a pediatric geneticist with pediatrics background, I say the outcome is not so bad. If the counselor tells that the achondroplasia, a lot of problems, family will terminate. But this is not the case. And those all late diagnosis, one has to give an importance to the rights of the status of the fetus as a human being, and would really consider termination only if there is a very, very definite abnormality and also not treatable abnormality. Then only the option of termination may be discussed with the family.
Thank you, madam. It was wonderful. And she made it very clear about three aspects of it. One, it is essential that you need to evaluate genetically, because if there is a genetic abnormality, possibility of a correction is remote. Second important thing is that they can store the samples for further evaluation at a later date. Third is that whenever you try to counsel these patients with this the genetic background, probably you are better off counseling these patients rather than without the genetic testing. Thank you very much for this input, madam. And now we move on to the situation where now with the MTP Act being notification coming up, and then we have the possibility of a late termination of pregnancy. Let us see what our Jyoti Bhaskar says about what are the procedures practiced in late termination of pregnancy if legally permitted.
Yeah, I think the question is if legally permitted.
Yes.
So We're waiting for that to come through and then do it. But anyway, the discussion lies over here in the late termination of pregnancy.
Yes,
So
yes.
categorize these patients, the decision into 3 areas we have to consider. First is what is the gestation? The second thing we need to know is whether she's had a previous hysterectomy or a cesarean section. And the third is what is the maternal preference? So considering all the 3 together, we are going to now decide what exactly is going to be the mode. So late termination, I'm sure we're talking of more than 28 weeks of pregnancy. We are moving on to that. So I'm going to only touch that area, though it's going to be too lengthy to discuss that. So in this, I will divide in 2 groups, one which do not have a scarred uterus and the other which have got a scarred uterus. So the ones which do not have a scarred uterus, we need to tell these patients 2 things. First of all, since the uterus at this time is not ready for a delivery, we will have to use methods which are going to ripen up the cervix and which are then going to create pains, as a result of which the whole delivery time, that is from the start of induction to delivery, can be prolonged. Although we have seen that 90% of cases it occurs within 24 hours, but can sometimes even take longer, up to 48 hours. And in very few cases, it may not be possible and we may land up doing a cesarean section or a hysterectomy for these patients. So as far as the method of inductions are concerned, present, all the data says and all our experience says that using misoprostol, which is prostaglandin E1, has been found to be very, very effective, both in ripening as well as in induction of the labor. The dose from various bodies, if you say NICE, we have FIGO, we have got FOXY, all of them, the dose tends to vary from a few micrograms here and there, but generally, if it is between less than 28 weeks, dose can go up to 100 micrograms given every 6 hourly or 4 hourly. But once it goes beyond 28 weeks, then the dose comes to the usual dose for induction in 3rd trimester, which is up to 25 to 50 micrograms. Now, exactly the way it is to be given, oral, per vaginal, or you're going to give it sublingually. Oral, if you're giving that, it has to be more frequent, every 2 hourly. And if you're putting it vaginally or sublingually, they're more effective. So then it increases to 4 to 6 hourly. We expect a delivery to take place within 24 hours. So the total dose may be maximum up to 5 hours. But once the cervix becomes favorable, we do an amniotomy, that is rupture of membranes. Then we follow it up by augmentation with misoprost, or we are doing it with oxytocin.
Very good. Thank you. Thank you.
Scarred uterus, just a word for that. Oral scarred users using a misoprost is going to be really difficult. None of the bodies recommend using misoprost for a scarred uterus. That is one area we can use the cervical, that's the Foley's catheter, for helping us to dilate it. Once it's dilated, do an ARM, and then we can augment them with oxytocin. Thank you very much, Dr.
Thank you. Thank you. So this is the procedure, and basically she has very nicely divided into a uterus which has a scar and without a scar, and based on that her management options are there. Now, what are the prerequisites and protocols followed in planning late termination?
So the first thing, most important, is, are we legally allowed? So we need to have a look at all the papers. Do we have the permission? Is it the permission from the medical board, from the district court, high court? As Dr. Khurana said, that's yet to be settled. But we need to have this permission, and we need to take a photocopy of that permission and attach it to the file, because that should be there in our permanent record. Apart from that, we need to review all her papers all over again. We should not take it at face value. We need to review all the papers as to the anomaly. What is the genetic status? Is it lethally not, patients not, it's not compatible with life. And that is why we are going to be considering termination of this pregnancy. Is the mother willing for it? Is the preference given from her? And then, of course, the mother's medical conditions, whether scarred, not scarred, all these things have to be taken, reviewed completely, and we need to take an informed consent. That is very important, or consent for induction and consent for the reason why the induction has been done. Based on that only, we then move on to the next step when we are going to take over for the termination.
Thank you. Very nice. Now, what are the major complications you encountered in late termination?
Yeah, so as far as the majors, first of all, it is PPH does take place, but it's in small number of patients. The reason being is that sometimes the labor gets a little too prolonged. Because you're going for 24 hours, you're continuously inducing. So it's a prolonged labor, and that tends to lead on to an increased chance of PPH. Sometimes you may have a retained placenta. So removing that placenta also can lead on to it. As far as pelvic infections, I have not seen many cases. It's comparatively rare unless we have ruptured the membranes and we are then continuing with prolonged oxytocin and everything, which goes more than 24 hours. Then there is a chance of pelvic infections, but otherwise we normally cover them up with antibiotics if we really feel there's any discharge. But more important, I would like to talk about is the rupture. So sometimes we get very enthusiastic. We are putting in more of misoprostol. Why is she not responding? We tend to go beyond it, especially if it is a scarred uterus and we are not very careful. Then that's the major complication we are actually talking about, is the rupture where we can lose the woman also in this particular case.
Thank you. Thank you very much. And I think it was a wonderful panel discussion that we had, and I had wonderful panelists who have really put forward very important aspects of this particular aspect of late onset anomalies and the ultrasound evaluation. Some key messages taken from all the panelists is that it is essential to include third trimester scan in our regular antenatal protocol. Third trimester scan should follow the same second trimester anomaly scan protocols. It is the time to accept that third trimester scan is more than a growth scan. Anomalies detected in third trimester will have a lot of bearing on psychological, ethical, social, and legal implications. Counseling these patients is crucial and should be subtle and case sensitive. Geneticist plays a major role in genetic disorder manifest in third trimester. Third trimester anomaly detection should follow involvement of referring physician, neonatologist, to take decisions regarding place, time, mode of delivery, and available management options. Present MTP Act has opened doors for newer options. It is essential to categorize these anomalies as correctable and non-correctable, or lethal and non-lethal based on the appropriate clinical data. If termination is the choice, then local legal stand should be taken into consideration and safe, appropriate procedure need to be operated. Thank you very much. Thank you very much for this panel. And I really congratulate my panelists and I thank them for being with me and taking through this panel discussion very successfully. Thank you very much.
Thank you very much.
Thank you so much.
Thank you very much, sir. And it was, I think, a fantastic panel. We really thought it may be a little difficult with second and third trimester, but I find the whole day would be less for us with such fantastic discussions to go on. And if permission, should I pick up a few questions Dr. Ashok Khurana has already answered, but if I go quickly, if a patient comes at 17 weeks for the anomaly scan with the history of previous miscarriage, should we do or we refuse it and call her again at 22 weeks?
Yeah, so when we talk about changing this window to 20 weeks, 20 to 22 weeks, we talk about the routine anomaly scan. That means the one scan that the patient must have in pregnancy according to the government of India, and according to us, the one that must be done even if we've done a 12-week scan. When it comes to a patient with the previous miscarriage, we need to look into why she had the previous miscarriage and whether there is a genetic basis to her history, or she has anything in her family history or anything in her own history, and whether there was anything in that previous fetus or not. In which situation she does not, we don't then consider the talk of a 20-week routine scan. We might even want to see it at 16 weeks, in which case we will do a complete anomalies evaluation at 16 weeks. So these have to be individualized. What we need to understand is that the routine scan that we've been pushing at 18 weeks in 1 day, 18 weeks in 2 days, is now pushed to the 20 weeks to 22 weeks window, because it gives us the luxury of time to investigate completely so that we give a proper prognosis. It gives us time for counseling. It gives us it has given our patient enough time to accept a diagnosis, to think over the diagnosis, not to take a hasty decision. We've heard those aspects in our discussion today, that the mother has rights, but the fetus has a right. The fetus has a right to die and the fetus has a right to live. And of course, you and me have to change the culture of this country. We just can't have designer babies. We have to have the acceptance that abnormalities or disabilities can occur in later life, and most of them do, and we accept life as it is. And therefore, we must never have a biased counseling or what we call a directive counseling. It should all lay cards on the table and then we come to a conclusion. So therefore, the routine anomaly scan shifts to 20 to 22 weeks. Specialized scans, depending on the patient's individual features, can be done whenever necessary.
Thank you so much, sir. And there's a question again from Doti Bhaskar, ma'am. If we have to do only one ultrasound in the third trimester, what's the right gestation to do so?
Jyoti Bhaskar, isn't it? Anytime between 32 and plus. I don't know, Dr. Jyoti Bhaskar, is she still there?
She's very much so.
Yeah.
So I wanted to know, am I to send at 30 weeks, 32 weeks, or 35 weeks? At the right time, if I have to do only one.
I think it would depend upon what you're looking at.
Yeah.
That's a predominantly for a low risk patient, that a low risk setting for a growth
If
scan.
you are bent upon only one scan, then I think somewhere around 35, 36 weeks would be an ideal time to do it. But otherwise, yes, a scan at 32 and a repeat scan at 36, 37, 2 would be more justified.
Thank you, sir. From Meenakshi Kumari, can isolated cleft palate detected prenatally and when?
Yeah, it can be dilated. Come on, please go ahead.
Yeah.
Someone was answering. Krishna Gopal, sorry.
Palate is difficult to diagnose. It can be diagnosed, but many times isolated cleft palate is very, very difficult to diagnose in the rest of the centers of the world.
Yeah, because it is not a part of the guidelines.
Yeah.
See, looking at the palate is not part of the guidelines, of course. So that is the reason it may, we primarily do not look for it. And if it is isolated, then we are more bound to miss it than to pick it up.
Right, sir. So in which congenital anomaly we have isolated MR?
Mental.
MR means?
I guess they must be referring to mitral regurgitation.
Yeah, mitral regurgitation.
Yeah.
Shiva ma'am is there.
Even if all ultrasonographic find isolated mental retardation or intellectual disability, as we say, prefer to say, is in a child who does not have any structural malformations or dysmorphic features. So naturally, in ultrasonography, you are not going to find any abnormality. And even if those who have mild dysmorphic features, they are not detectable by prenatal ultrasonography, even by 3D, 4D examination, because the dysmorphism is usually very subtle and evolves with time. So what I wanted to stress and convey to everybody, that though the families say we want a normal baby, the child should not have intellectual disability. So everyone should know that even if ultrasound is normal, 1% of the children who are born, 3% of the children who are born have intellectual disability of variable severity. And out of them, some of them may have ultrasonographically detectable anomalies, but still, if ultrasound is normal, the possibility of intellectual disability cannot be entirely ruled out. Even if microcephaly is not there in the third trimester, still if microcephaly can manifest postnatally. Rett syndrome, the microcephaly may appear at the end of 1 year. So the point I wanted to convey, that when everybody wants that even if there is smallest abnormality or a possibility of abnormality like aplasia of corpus callosum, if investigations are normal and it's isolated, then 80% of children have normal intelligence. In that situation, just to say there is a possibility of 10% or 3 to 10%, and we will terminate because of aplasia of corpus callosum. As a doctor, we should communicate that this is not justified. And here, when we say non-directive counseling, but when it is coming to termination after 20 weeks or after 24 weeks, I become very sensitive that it's our responsibility to convey that whether that particular abnormality justifies termination or not. Just the idea that we want 100% normal baby and we cannot risk of taking off 5% possibility of intellectual disability and please terminate. So we have to strictly convey that this is not justified unless there is a major abnormality and definite abnormality.
Yeah,
so if aplasia of corpus callosum and microarray shows some deletion which is always associated with intellectual disability, then termination will be justified. So now the responsibility of doctors, and here I see in audience there may be a lot of young obstetricians, so it's very important that we have to take our responsibility that many normal children may not be terminated just for the fear or the slight possibility that the child may have intellectual disability. Sure. And hence that abnormality should be there definitely, and it should be always associated with intellectual disability, because in microarray there are some deletions which increase the susceptibility to intellectual disability, but are present in many normal individuals who do not have intellectual disability.
I
So
think
because
in
just because
one
30
word we
weeks
can
you
say that it is
have
a,
identified it, you should not terminate. And the same thing about other treatable malformations or other abnormalities. If the child is born 2 days after and then the child has abnormality, parents would say, do everything and treat my child. The same attitude should be there even earlier also. And the status of the fetus as a human being and his status to the right it is there since embryonic life. But as the gestation age advances, the status of the fetus as a human being definitely increases, and we have to give respect to that and also convey this message to the all audience of obstetricians that terminations after 20 weeks should not be taken very lightly.
thank you, ma'am. Yeah.
Thank you so much, madam, for the valuable inputs. I think it's a very, very interesting and an unending discussions, and our tummy is calling for a dinner now. So
Can I make 2 points here?
Right, sir.
Just
Sure, sir.
short points. One, I think now it's becoming very, very important that once the pregnancy is diagnosed, now we need to, classify it into high risk and low risk, because we have so much options of the period at which different scans can be done. So all this 22 week scan, what sir has been talking about, and he's again and again saying, yes, this is for a low risk population. So once you have labeled this pregnancy as a high risk, I think the ultrasound plan should be tailor-made for that particular patient. Like, okay, you're going to have your NT scan then, because these are the ones who would actually require, based on what is the criteria on which this patient has become high risk. And second important point is, we are all very excited about this going to 20 to 24 weeks, and that we would be doing our anomaly scan with a bigger fetus. But it comes with a caveat. See, our responsibility becomes much more than what we were doing at 18, 19 weeks. We could excuse ourselves from so many things, that the sulci, the parieto-occipital sulcal comes only after 20 weeks. The vermis is not fully formed. But once we move to 22 weeks, I think the protocols will increase, and we'll actually have to start looking for much more things than what we were looking for at the 19 week scan. It comes with, it's not all happy. There is something that we need to change over also.
Excuse me, I just want to say, because this question was again and again being asked about 20 to 22 weeks, I still feel that 18 to 20 weeks, the visibility is quite good. And probably if you do continue that malformation scan 18 to 20 weeks, then there is enough time for getting investigations done, getting their reports in 15 days, getting follow-up. Like if there is ventriculomegaly, then we say in 2-3 weeks whether it is going to increase or not, hydronephrosis. So I myself still feel that it is very important, and that the scan for malformation we continue to do at 18 to 20 weeks. And probably you should look out the data, how much exactly there will be gain. And for that gain also termination increases, as well as the diagnostic investigations reporting rate will also get delayed. So I still feel that we should continue.
Madam, that is genotype coming.
No, I would not agree there. I would really feel that, we have data enough. We've had this data for 30 years. And our other problem is that we now have a universally obese population where the BMI has shifted from 16 to 2 decades ago to 26 today. I mean, our average in Delhi, for instance, BMI is 22 to 28. And 50% of the patients are being recalled for a second scan because we're not happy with seeing the heart or some part. And that seems so unfair, because we now have time not only till 24, we have time till still further. And even if I do a scan at 20 weeks, I still have 4 weeks in which to take a decision without having to go to a higher, to the courts at all. And so I would really feel that we shift to 20, we give a better diagnosis. We, as Bimal was saying, extend and look for more things. And our corpus callosum, for instance, is so difficult to see in the obese hirsute individual with abdominal adiposity. So for me, I've already changed over, because that guilt of calling a patient back twice was really unfair. And the effort we have to make. A scan at 20 weeks is now taking me about 25 to 35 minutes. A scan at 18 weeks used to take me about an hour or so. And that was a huge thing that the patient had to pay for, because I charge them for time. And the same thing happens even if you're not charging. We need expertise in a hospital. We need time, and a hospital's overloaded. So I would still think that if I have those 4 weeks, I'm quite happy to see a 20. May not be 22, except, sometimes when the patient comes in late, but 20, yes. So
So
I
I'm
would
saying
request
18 to
to
20,
reconsider
and you say that probably around 20 is okay, 22 to
20,
20.
because there's a
So,
huge difference between
that's
18
what
and
I'm
20.
saying. Around 20, and no point in delaying more than 20,
Yeah,
because
20 is very
not that the
comfortable.
law has allowed us to terminate up to 24, but still, I think as the gestation age increases, also the same thing about termination decision becomes difficult for the patient, for the counselor, for the obstetricians, because termination is ultimately really they are taking somebody's life. So legally, if somebody is allowed and we also feel justified, still probably what status the fetus has around 20, less than 20 weeks, what the families have in their mind that the baby is moving, the baby has started moving, then they're emotionally taking decision after 24 weeks is very, very difficult. So
No.
because we have been doing
I think, well, see, the question of timing, that is 18 or 20 or 22 weeks, it all depends on the patient. As Ashok said, as the BMI is increasing, it is not just to do a 18 to 20 weeks and be done with it. When you have a provision where you can reevaluate them, which you are again doing it, anyhow, when you are doing it about 18 to 20 weeks, you are calling them back again after 1 week. It is as well do it at about 20 to 22 weeks, because you are more comfortable, you are more confident about what you are seeing. It's not that we have been trained, we have already been trained to evaluate these fetal anomalies between 18 to 20. You are extending it and being much more, gaining more confident and being much more comfortable in giving a diagnosis. I think that is not a debatable thing. It is the question of each patient. That is the reason why it has to be tailor-made. It has to be case sensitive.
because if you do amniocentesis at 22 weeks, we can give results in maybe 15 days. But as I say, that laboratory also needs some time. So karyotype को 3 weeks लग जाए और microarray को कभी-कभी cell culture करके लेना पड़े. So you have to keep about 3 to 4 weeks for investigations. And as you say that if the lady is obese and the circumstances demand, but probably if somebody has come or ready to come, then purposefully delaying for
No one delays
at 18
purposefully.
weeks.
It is not purposefully done. It is done with an intention to give a better diagnosis and a confident diagnosis.
Laboratories, as I said, you have to keep time for laboratories for at least 3
No,
weeks.
but
So that
for the
Madam,
time for laboratory, you don't need to compromise on your scan date.
Yeah, genotype at the cost of phenotype. And then if the phenotype suffers, the genotype is going to suffer, ma'am.
Yeah, definitely.
So I think that should not be the criteria to decide when to do. Based on the genetic evaluation, you should not delay it, because you need a confident diagnosis. You need to suspect the anomaly. Then only you'll ask for a genotype, or else you don't even ask for it.
Actually, I would like to say something.
Please.
I agree with Dr. Shubha. I'm telling you honestly, being a obstetrician, even patient has been referred to me, and they take 1 week to 2 weeks to come to me. The practical problem. Even someone has diagnosed 18 weeks, there's some anomaly. Then they have not come their time. Ghar mein kuch ho gaya, and they are coming after a week or two. Then they are coming at 20 weeks. So practical things are absolutely different. Dr. Ashok Khurana, Dr. Parveen, Dr. Sani, they are the stalwarts of some field, but this is not a general scenario. The general scenario is absolutely different. That we are referring the case, then 18 weeks. I agree with Dr. Shubha practically. Even I go for a repeat scan, I don't mind. But if 18 weeks is coming to be normal, I've got enough time, and even your NIPT, non-invasive, that takes even 10 days to come. So if you are suspecting something and you want to go for it, there should be enough time. Then absolutely at 24 weeks, it's running to, yes, get it about, patient is confused whether to go or not. If beyond 24 weeks, a district court or high court is required. Things are saying easy, but it is very difficult to go for
To
it.
me,
This is a
extending to
practical
24
problem.
weeks is because by 20 weeks, if you diagnose some things, and then you need some time for evaluation, and that's why the extending to 24 covers that patch also. And
Yes.
some of them, so you don't have to hurry at 16 to 18 weeks, but you can
Yeah.
do it 18 to 20 weeks and have enough time for further
Yes.
evaluation, follow up, and see that that particular ventricular hydronephrosis is progressing or not progressing. That gives enough confidence
Only
to
today I
decide.
got a case.
Also.
Today I got the case with one-sided multiple hydronephrosis, the other side is pilectasis. What to do? Rest of the things are normal. She's at 23 weeks gestation. I referred it to the best center at Varanasi. I discussed with the sonologist. He said, Madam, at this gestational age, we should not go for termination. We should go for a follow-up scan. Then we counseled the patient that look, and there is no 2D echo was normal. Other things are normal. So he said, Madam, let us wait for another 2 weeks. So this is a practical thing I'm discussing with you. And previous scan, 18 weeks was also
But
there.
we've already discussed one thing, and that is that we can't change embryology. So,
That's
so the
true.
urinary system will give me a decision only at 28 weeks. It's not going to give me a decision at 20 or
That's true.
22.
But repeat
But what
scan
I'm
is
saying
agreed.
is
Repeat
exactly
scan is
what
agreed.
Bimal said. You
Accept
know,
the
Dr. Bimal
limitations.
Sani very
There
clearly
are
said,
limitations. Even if you change to 24 weeks, still there will be some
Yes.
disorders will be missed, and
yes.
that
So you
That's
agree
what
limitation
that
I'm
at
we
saying.
know.
24 weeks
A
also we are
third,
not very
third
sure.
trimester
So how
scan.
can you be very sure at 20 weeks? So
No.
it is an
So I think
evolving
that the
thing.
message
That's
that must go, as Praveen said, is we need the anomaly scan at 20 weeks.
yes.
So 18 to 20 weeks, that's what I'm saying. Don't delay beyond
No,
20
the 18
weeks.
is
That's
too
my
early.
point.
The
Too
18
early.
is too early.
That's the point. Don't
They
delay
make a
beyond
point
20. That's what I'm saying.
You
Don't delay
see,
beyond 20.
when we had a 20-week deadline, we said 18 weeks. We have a 24-week deadline, and we're still seeing 18. And that's not logical because for your extensive genetic investigation, you're going to need, as Dr. Bimal Sani said, a phenotype. My entire genetic investigation is my ultrasound phenotype. And otherwise, how will I start talking about things like some of the other conditions? And so I would like people to go home with the idea to say that it just has to be 20 weeks.
Yes. I think we need
Stretch it
to.
to 22,
Yes.
yes, but 20, yes.
All over the world,
Like
all over the
Dr.
world,
Bimal said that we have to differentiate between high risk and low risk. And I just would like to remind and request everybody to draw a pedigree during the first visit. And that is how you will identify high risk patients. And
True.
that is the simplest,
Very correct.
cheapest
Absolutely.
genetic test for everybody. And
Yes.
I
Any
think that
tool
is
for
the
autism,
message.
madam?
Sorry?
Anyone? Any tool to diagnose autism?
Yeah, so autism, about 20% will have genetic etiology, some of them chromosomal, some of them monogenic disorders, even fetal rubella causes autism. And for such type of patients, the other thing is that when you draw a pedigree, if there is a previously affected child with some disorder in the family, then preferably pre-pregnancy evaluation should have been done. But if during the first visit in first trimester, when you do ultrasonography, if you draw a pedigree, whether it's a fetal medicine specialist or a radiologist, everybody should draw a pedigree. And if they say that they have a child with autism, just refer that child for genetic evaluation to a pediatrician or a geneticist. Because I talked to some ultrasonographers, and they say sometimes they say there is an affected child we have brought, but they say we don't see, we say we will see, look at the fetus, not at the affected child. The first important step would be to look at the affected child, whether it's in the same nuclear family or the cousin or a maternal aunt's son, whatever is there. So this is the child should be evaluated. Then we can give proper counseling and investigations for the fetus in utero.
Thank you.
Krishna has been wanting to say something for a
yeah.
while.
Yeah, with due respect to all the views, I want to summarize it. Summarize it that we are talking about termination. Termination for what? We are termination for the congenital malformation. So we have to choose the best period in which we have the maximum number of malformation we can see. So the best period for all of us and from all the data throughout the years is like 20 weeks plus. So I don't think that there should be a discussion about this. We have to select the best period in which we have to see for the maximum number of defects. That is the 20 weeks.
Thank you so much, Krishnapal sir. And I think with this healthy interactive discussions, we brought about, cleared up so many clarities and the confusions were there. So thank you so much. And I think we come to the end of the session, and my special thanks to our president, Dr. Anuradha Khanna ma'am, and also Dr. Ashok Khurana sir for his excellent presentation, brought about all the newer concepts to us that we need to follow, and the fantastic panel moderation by Dr. Tielan Parveen sir, and the learned panelists, Dr. Jyoti Bhaskar, Dr. Bibal Sani, Dr. Krishna Gopal, Dr. Shubha ma'am, Dr. Ankur, for giving really crisp and clear take-home messages. And thank you to our esteemed chairperson, Anuradha madam and Tamkeen Khan ma'am, for their useful inputs that we got today. And also Krishna Gopal sir needs a special thanks. He's always inspiring, and his unflinching support just a call away from us. And thank you to the delegates who made this session so more informative, putting in questions in large numbers, and our academic partners, LifeCell and Lal Pets, for supporting. And of course, we have Mr. Vishal and Subit always there for us, giving us this platform and staying with us till the end. So I think good night and goodbye till we meet again.
Yes,
So
thank you, and
so much to all of you.
congratulations, Ritu. It was a
Thank you,
wonderful
ma'am. Good night.
Thank you so much, sir.
Thank you, Ankur. Bye.
Yeah.
Good night.